Dr. Joseph Zorek, a PharmD and a board-certified geriatric pharmacist. Dr. Zorek joined the University of Texas Health Science Center at San Antonio in July 2019 as director of their Quality Enhancement Plan, linking interprofessional networks for collaboration, shortly known as LINK, and he's an associate professor with tenure in the School of Nursing. LINK is an institution-wide effort to increase interprofessional education and to integrate it into the curriculum throughout the university. Dr. Zorek previously served as director of the Interprofessional Education and associate professor at the University of Wisconsin-Madison School of Pharmacy. He recently represented the National Center for Interprofessional Practice and Education on a collaborative project with the health profession accreditors, which result in a national guideline known as Guidance on Developing Quality Interprofessional Education for the Health Profession. Welcome, Dr. Zorek, and thank you for joining us today. The screen is yours and you can start your slides.
Thank you very much. Give me 1 second to start my slides. It was a very kind introduction.
Take your time and you're welcome.
Okay, can everyone see my slides? Okay.
Everything's
yes,
fine.
Yes, you can go ahead, Doctor.
Okay, thank you very much. And it's an honor for me to be here. I very much appreciate the invitation and the kind welcome, as I had mentioned. So yes, absolutely. So over the course of the next 45 minutes or so, I'd like to lay the groundwork for you all for a movement that has been happening within the US for many decades, but really has not gained steam for probably up until the last 10 years or so. And now that this interprofessional education movement has really sort of entered this phase within the US of full implementation, there have been a lot of lessons that we've learned. And so today I want to share some of those lessons as far as number one, just a basic understanding of what is interprofessional education and collaborative practice. Why is it so critical for the US healthcare system? Describing some of the imperative, where did the drive for this movement come from? And then I'd like to finish by sharing what we at our institution, UT Health San Antonio, how we are advancing IPE in this time of COVID-19 crisis. So to begin with, I wanted to start at the very beginning. What do we mean when we say IPE? It's an acronym that stands for Interprofessional Practice and Education. In the introduction, it was mentioned that I had worked with the National Center for Interprofessional Practice and Education. And that the naming of that national center and the transformation of this acronym IPE from historically purely interprofessional education to interprofessional practice and education is important, and it has many implications. So the definitions for interprofessional practice and interprofessional education are shared on the slide. I always highlight interprofessional practice first. This is multiple health workers from completely different professional backgrounds coordinating and collaborating amongst themselves, synergizing their various skill sets in order to advance high quality patient care. This is care for families, patients, caregivers, but importantly, in recent years, there's been a new emphasis on the care of entire populations. So I start with practice because the reason that we do interprofessional education, the reason we're trying to transform our curricula to teach students through interprofessional education is entirely because we want them, when they get out to practice settings, to be able to collaborate with one another, not just with others in their profession, but also with others effectively from other professions, such as medicine, nursing. In the US, there's been growing collaborations between pharmacists and nurse practitioner programs, physician assistant programs, occupational therapists, physical therapists. So basically, pharmacists have found themselves at the forefront in many ways of IPE because medications are used and they influence the work of many other health professionals. Medications are in some ways a vector that connects pharmacy to all of the other professions. And the ultimate goal of IPE is to improve what are called quadruple aim outcomes. Those 4 outcomes are listed on the slide, essentially improving the health of populations, the experience that patients have within the healthcare system, increasing provider work-life balance and provider satisfaction. We have recognized in the US over the course of the last decade that one of the threats to quality healthcare is a deterioration, a burnout of healthcare providers, including many pharmacists. And so one of the aims of IPE is to offset some of the negativity that when health providers are working and practicing in silos, that they experience this level of burnout and stress, that working effectively in teams oftentimes offsets that burnout. The last of the quadruple aims is within the US, increasing cost efficiencies. So healthcare as a product of as a portion of our gross domestic product is enormous. And so cost implications for any kind of healthcare innovations or educational innovations that are intended to influence the practice of healthcare are also seen as very important. So essentially, we plan and implement and evaluate interprofessional education activities because we're trying to improve interprofessional practice with the belief, and there is emerging evidence over the last 15 years or so, that improved interprofessional practice leads to better health outcomes and several of those metrics from the quadruple aim that I mentioned. So one thing that, giving a talk to an international audience that I think is very important, that I'd like to stress, within the field of IPE, there is debate as to whether IPE is globally applicable, meaning are the competencies we're trying to teach in the US applicable to those that would be important in Iraq, in Australia, in Europe? And there are people who fall on different sides of this argument. I'm one that I believe firmly that interprofessional practice and preparation for interprofessional practice needs to be individualized because our practice environments look very different. I'm going to show you some examples of what pharmacy practice looks like in this interprofessional setting. And I know from a previous talk done this February in the United Arab Emirates that some of that practice is not replicated or is not the same throughout the Middle East. Some of it is, some of it isn't. So if we're trying to prepare students through interprofessional education to practice collaboratively, we need to individualize our education approach to be situated in the context of the practice environment. So my talk from here on out is about IPE and collaborative practice in the US from the US perspective. These are what pharmacists are experiencing and what we're prepping pharmacists for in the US. And I know full well that those dynamics are very different in Iraq or in other parts of the Middle East. So I say that just to throw a caveat out to say, what I'm sharing is not intended to be lifted and placed in the context of your institution. Instead, it's to be used lessons learned from our experience that can be applied to your local context. So this is the cover of a book that I have coming out in November or December of this year, published by McGraw-Hill, essentially outlining, it's a textbook. It is a textbook mostly for early learners in pharmacy. These are students who are new to the profession. And when students enter pharmacy programs in the US, many of them have no context or understanding of what pharmacists ultimately do in terms of practice. They understand community pharmacy. They may understand that pharmacists work in hospitals, but have limited understanding of what they do. And so this book is intended for early learners in pharmacy to open up their eyes and open up their opportunities to customize their educational path so that they can see themselves practicing in all of the different interprofessional contexts that exist within the US healthcare system. And what I'd like to do is share some case studies from this book. And again, they're modeled off of, you saw from the cover, illustrations. It's a graphic novel approach, but it's not meant to be funny or entertaining. These are real life stories and real cases told to a younger audience, these early learners in pharmacy. Specifically to highlight how pharmacists are impacting health outcomes through interprofessional practice. So this scene will look familiar to many of you, a pharmacist and a pharmacy technician in a community pharmacy setting with patients queued up. And you see that for us, the weekend starts on Fridays, Friday afternoon. People are trying to pick up their medications before the weekend. We then see the beginnings of what interprofessional practice looks like in a community pharmacy. A lot of this happens via the telephone or now via the sharing of electronic records. So the pharmacist in this setting is working on behalf of a patient to get an insurance prior authorization for the patient to get a medication. The pharmacy technician is working to get also a prescription for a patient who needs anti-nausea medications that you'll see in this next slide. The stress that this patient is experiencing and the pressure that is putting on the pharmacy and the pharmacist is due to chemotherapy treatments. So this patient is in a hurry, ready to get home, feeling sick, and there's pressure being put on the pharmacist to deliver medications in a safe way. On the left-hand side of this slide, we see the pharmacist. You don't see the pharmacist, but you see who the pharmacist is talking to. And so the pharmacist is on the phone with a nurse who is working on behalf of a physician assistant. It's my understanding that the profession, the physician assistant profession, is not widespread throughout the Middle East. Physician assistants hold prescriptive authority. They work similar to physicians in many capacities, seeing patients, writing prescriptions, driving drug use. And so the pharmacist on the phone in the community pharmacy is working with this clinic to clarify the correct dose for a pediatric patient. The pharmacy technician, meanwhile, is working with the child's mother and another patient who is also waiting to get medications, to waiting on the interprofessional work of this pharmacist. The story continues with the pharmacist having worked with the insurance company, clarified for the patient, and all is well. They're moving forward through the delivery of recommendations to get immunizations. This particular case study ends with a nurse practitioner calling with an unknown request, but another opportunity for the pharmacist and the pharmacy technician to work in an interprofessional manner for the safe and effective use of medications. We see that the pharmacist has clarified, corrected the dose with the PA. The medications were obtained through another collaborative effort for the patient who is the oncology patient. So another area that pharmacists are working in the US are embedded inside primary care clinics. So this changes the interprofessional dynamic in many important ways, because it's no longer in the traditional setting where a pharmacist is working with others via telephone, fax, or electronic medical record. Instead, many pharmacists in the US are working alongside physicians, nurses, PAs, nurse practitioners, and others inside the same clinics. So you see this next story, support, opens with a pharmacist making a call to a patient who was recently discharged from the hospital. Pharmacists in clinic settings are often working in areas that we call transitions of care, making sure that when patients who are sick in hospital and go home, when they go home, that there are not errors in their medication use, that they understand their meds, that they're minimizing toxicity and increasing efficacy and safety. So this pharmacist is making a phone call to a patient who was recently discharged from the hospital and letting this patient know that based on their labs, they're ready to restart their lisinopril. That telephone call is happening inside of an interprofessional team workroom, which is another fixture within medical clinics, common workspace where pharmacists are working alongside, in this case, a nurse practitioner who, like a physician assistant, has prescriptive authority, is seeing patients, is writing medication orders and prescriptions, and a physician. In this story, both of them are leaning on or relying on Maddie, this pharmacist, for guidance on medication use. The nurse practitioner is looking for advice and guidance on using the appropriate medications for hyperlipidemia, and the physician is concerned that a patient of his has a rash and is looking for a possible drug-induced side effect. So the pharmacist in a clinic setting consulting for a physician is exploring whether or not the rash that this patient is experiencing is being caused by a drug, and is using a validated tool to assess whether or not that is happening. What this pharmacist comes to the conclusion and makes a recommendation that, based on her clinical expertise and evaluation, that this patient is experiencing a drug-induced rash from rivaroxaban, and makes a recommendation to the provider in an interprofessional, perfect scenario to improve medication use through her clinical expertise. Simultaneously, we see that this pharmacist was working on the drug information request from the nurse practitioner about which of these new agents for dyslipidemia is most appropriate. And what you see here is, after resolving the drug rash problem on behalf of the physician, this pharmacist then works with the nurse practitioner to advocate for the use of a preferred agent. She's sharing her drug knowledge, and she's sharing the research that the evidence that she has obtained through her research on efficacy for one agent versus another. And she's helping this nurse practitioner obtain the medications for her patient. This particular story ends with another example of clinical activity that pharmacists in the US are performing on a regular basis, which is the one-on-one direct consultation of patients on how to use their medications safely, what to look out for in terms of side effects, serious adverse effects, and the like. The last story I wanted to share with you an example of interprofessional practice in a community pharmacy. I wanted to share an example of interprofessional practice in a clinic environment, and I want to share an example of interprofessional practice in a hospital environment. So the story of this superinfection story begins in a patient's room with the pharmacist rounding with the attending physician, collaborating on the case of a patient who has been admitted repeatedly to the hospital for urogenitary infections, and over the course of that period has received multiple antibiotics. We see the pharmacist working in real time, in person, helping the physician make appropriate decisions. I'm not sure how clear this comes out from the computer screen, but what they're looking at is the culture and sensitivity results from the patient's urine, where she is growing gram-negative rods that are showing resistance to amoxicillin, ceftriaxone, and susceptibility to gentamicin, levofloxacin, and nitrofurantoin. The physician is wondering whether nitrofurantoin would be the appropriate choice, and the pharmacist in this illustration is showing that this particular patient has a kidney infection and not a bladder infection, using her expert knowledge of these medications, knowing that nitrofurantoin accumulates in the bladder, does not have high penetration to the kidney, and ultimately recommends the use of levofloxacin for this patient's infection. What we see then, after working interprofessionally with the physician, the pharmacist then has the responsibility, like in the previous case, of educating this patient on the use of levofloxacin, their side effects, and what to look out for in terms of serious side effects. We fast forward in this story to the patient's home, where we see her daughter wondering whether her mother is okay. She's spending a lot of time in the bathroom. And the story ends with the patient back in the hospital, not for a urogenitary infection, but instead for a C. diff infection, which is a common infection that really has been ravaging hospitals throughout the US because of inappropriate medication use in many contexts. The reason this story ends on a negative note or a sour note is to introduce to the students who will study these cases the idea of responsibility. Is this the pharmacist's responsibility for this negative outcome? Is this the physician's responsibility? And ultimately, it is a team responsibility. The idea, one of the key constructs in interprofessional practice is that we're working together, we're sharing our expertise, we share, the physician and the pharmacist and the nurses and all the others share the rewards that come from good progress. They also must share responsibility for negative outcomes. So having seen what interprofessional practice looks like, you can get a sense of what we're trying to prepare students for what we're trying to prepare pharmacy students for. And here I wanted to share with you photos of actual interprofessional education. So our PharmD students are dispersed throughout this classroom, working in interprofessional groups with nursing students. These are BSN, is Bachelor of Science in Nursing in the US, and MD students. These are our physician, these are our medical colleagues. They will graduate as physicians in the US. And what this example shows you classroom-based IPE, where we, in this particular class, we're teaching about HIV and how teams, interprofessional teams, deliver the highest quality of HIV care to patients. And so these particular students are in the first year of their training, first year medical, first year pharmacy, first year nursing. And they are learning simultaneously as they're learning about HIV, they are learning about what do pharmacists bring to this team, what do physicians bring, what do nurses bring. And so the idea with classroom-based IPE is that we're teaching them content, but we're simultaneously teaching them the roles and responsibilities that physicians, pharmacists, and nurses occupy. And we're teaching them to respect one another. We're helping them build relationships, and we're helping them learn that they can and should rely on one another as they mature through their program and experience later in their careers interprofessional practice. So I shared that inpatient scenario of the superinfection. And one of the ways that we prep students in the US for interprofessional practice in a hospital setting is through the use of simulation. And in this case, what you can see is a pharmacy student, a medical student, and a nursing student. These particular students are later in their training, right before they go out into their clinical rotations. And so this patient, who's a dummy, this patient has experienced, basically they've decompensated very quickly, and it's because of a drug error. This patient came to the hospital, they were brought to the emergency room, so to speak, because they had a supposed infection. The medical team started an antibiotic, a penicillin-based antibiotic that this particular patient was allergic to, and they had an anaphylactic reaction, and the patient decompensated quickly. And what this team of students, the pharmacy, medicine, and nursing student experience, they came to the scenario during the decompensation phase. And we have a real live actor. This actor is playing the role of a caregiver who is in the room, is very stressed out. And what we do is we plop these teams into the situation. They've been trained on how to work together as team members, and we let them handle the situation as it unfolds. Another example of IPE is what we call co-curricular IPE. And this is a prevalent form of IPE in the US, where we have students from different professions going out into the community, or they're participating in competitions, case competitions, and they're doing it in a voluntary basis. And so this particular set of students organized a co-curricular IPE activity at the University of Wisconsin that I oversaw, where veterinary medical students, so veterinary students, partnered with pharmacy students, and they went to local veterinary clinics, and they educated patients, they educated pet owners about adherence, the importance of adherence to medications. It started with teaching about adherence to how to administer drugs to pets, but then we trained them on how to transition that conversation to asking the pet owner themselves whether or not they had questions about their own medications or medication use, at which point the pharmacy students then provided education and guidance about medication adherence for the pet owners or the humans. The last example I want to share with you about is at the tail end of pharmacy school. So we typically start with classroom-based IPE. It's a safe environment. We progress to a safer environment, but a more challenging clinical one in simulation. The students are going out into the community largely on a voluntary basis, and they're engaging with real life patients. And then we end on the end of our IPE programmatic approach in the clinical realm, where they're working alongside students and practitioners from other professions in the actual delivery of care. And so this photo that you see here is a pharmacy resident. This is someone who has a PharmD, but they're doing additional training with working with a pharmacy student and a medical student to care for a real life patient that you see on the right side of this photo. And this patient is coming for a visit in a geriatrics clinic. And what the pharmacy team is handling medication history, they're making recommendations on improving medication use, and our medical counterparts in this clinic are conducting the various physical assessments and exams. After they meet with this patient, the team comes together, also with nurses, oftentimes with social workers, to generate a care plan together for this particular patient. And so clinical IPE is at the tail end of our programmatic approach. So what you see here is a progression from top left to right and then bottom left to right in terms of the complexity of IPE pedagogies, all of which are targeting different interprofessional competencies that we're trying to teach students. It begins with simple interprofessional socialization so that they can get to know one another, they can get to trust one another, they get a sense early on of where different professions have strengths. And for pharmacy, it's very important that other students, when they're learning their profession, are simultaneously learning that pharmacists and pharmacy students have unique expertise and knowledge as it relates to medications, and that they should be treated and seen as medication experts. That all progresses into practice, where we end in this clinical IPE environment, which is really the pinnacle and the end of the IPE curricular approach prior to graduation and entrance into clinical practice. So the next section of the talk, now that you can get a sense of my perspective on interprofessional practice and education as it relates to pharmacy, I want to give you a sense of why in the US we have this IPE imperative. Why have we moved from very siloed education into a realm where we're pushing very hard to transform educational institutions in order to deliver high quality IPE. So many of you will recognize the name Institute of Medicine. This is one of the leading organizations in the US, sort of setting standards for high quality healthcare. This photo is from a book from the IOM's very first publication in 1972, which was focused in 1972, the very first report on trying to promote interprofessional education, knowing in the 70s that there was a problem in the US healthcare system with health professionals not collaborating and coordinating with one another, and the negative impact that that has had on patients, families, and communities. We fast forward to the late 90s and early 2000s. The IOM put out 3 key reports that have completely transformed education in the US. The 1999 report To Err is Human highlighted that poor teamwork causes many errors, increased injuries, morbidity, and importantly, and sadly, mortality. So there are consequences related to a lack of teamwork and interprofessional collaboration that directly leads to many patient deaths that are preventable. In 2001, they proposed that if we are going to work in teams, we need to train in teams. And in 2003, a report came out that closed this series that essentially laid the groundwork of what needed to happen in the educational system for us to transform and address this real large deficiency. I always share this 2001, this slide from the 2001 Crossing the Quality Chasm, because it highlights that interprofessional practice and interprofessional education always needs to be focused first and foremost on the patient and what patients should and can expect from different healthcare providers, including pharmacists. This idea that it's unacceptable for physicians, pharmacists, nurses, and all of the other professions to not be collaborating, cooperating, and coordinating with one another. That is a core basic expectation of any patient should be that their healthcare providers are coordinating with one another and cooperating with one another. The 2003 report that laid the groundwork for transformation highlighted that the core competency in black here, these are 5 competencies that every healthcare student should be competent in. The absolute supreme competency was the ability to work in teams. Now, I don't want you to focus on reading all of these recommendations verbatim, but I wanted to highlight 2 key recommendations that came out from that 2003 report. The first was that we needed a common language, that from pharmacy to medicine to nursing, PT, OT, social work, we were not speaking with a shared vocabulary. We needed a common language first before we can start collaborating with one another. The second recommendation was that the accrediting bodies, and I know that Mike Rouse spoke to the group yesterday. The folks like Mike and his counterparts at ACPE and their counterparts at the medical accreditors and all of the other accrediting bodies, those folks needed to speak with a unified voice in order for us to transform education and move IPE meaningfully so that students were prepared for interprofessional teamwork. Those 2 reports led to the creation and the advancement of IPE in really significant ways. A lot of the significant progress is due to the work of 3 organizations: Ipe, the National Center, and Hpac. Ipe is a collaborative of the professional associations that represent all colleges and schools of health professions. And I've highlighted AACP, which I know you're familiar with. AACP was a founding member of Ipe. Ipe put out a competency report, essentially highlighting that all health profession students should be trained and competent in teamwork, interprofessional communication. They should understand the roles and responsibilities of others on the team, and they should have some shared values and ethics. Essentially, they should have a level of respect for other professions, and they should trust and lean on one another's expertise. This report has 39 competencies. Those 39 competencies have basically become the basis for the planning of IPE activities across the United States. The National Center, if you're unaware, I just wanted to share their website, has become a clearinghouse, an expert clearinghouse to promote best practices and to share best practices. The National Center partnered with the Health Professions Accreditors Collaborative. This is an analogous organization to Ipe, but the Hpac is the actual embodiment of that recommendation back in 2003 that the accrediting bodies collaborate and coordinate with one another on a large scale. ACPE is one of the founding members of Hpac. And so the National Center partnered with Hpac to develop the consensus guidance that was called for back in 2003. And that is captured in this document that was published last year. The goals of the Hpac guidance document are to facilitate quality IPE and to set clear expectations, not just in pharmacy, but in every health profession, so that there is a shared vision on how to advance IPE for the health professions. Now, because we got started a little bit late, I'm going to speed through the other components of the Hpac document. Basically, I want to leave you with the notion of the biggest piece that was promoted within the Hpac document was that IPE activities, curricular, and I shared with you classroom-based IPE and simulation-based IPE. Those would be considered curricular. Extracurricular, another word for co-curricular IPE, and clinical IPE that programs health professions, colleges, and schools throughout the US. The recommendation is that they should be building IPE plans that include classroom, simulation, co-curricular, and clinical learning activities that are integrated into the professional curriculum and that span the entire length of the curriculum. So that is a bold vision for transforming education in the US. Like I mentioned, I'm going to fast forward quickly here. One of the interesting things that was shared by Hpac, and this was prior to COVID, was that we should start to consider collaborative online learning. And I highlight that because it's relevant in the era of COVID and trying to do IPE without the ability to meet face-to-face. So in essence, Ipe gave us in the US a common language where we could speak to our colleagues in the other professions. The National Center and Hpac gave us a consensus guidance. They gave us a vision to move forward. And I want to close the talk by sharing my own personal case study of advancing IPE in a time of crisis. So it was mentioned in my introduction that I'm the director of linking interprofessional networks for collaboration at the University of Texas Health Science Center at San Antonio. I joined this campus in 2019 in order to lead our quality enhancement plan. Our quality enhancement plan is designed to facilitate collaborations and connections across our 5 schools. So we have 5 schools and roughly 70 degree programs. We have about 3,500 students on our campus spread across those programs. And the vision of our QEP link is to increase the amount of IPE that is happening on our campus and to prepare our students from graduate programs throughout, from nursing and medicine, all of our health professions programs, to prepare those students for collaborative practice. This schematic shows the organizational structure of the group that I'm leading. My office oversees and spearheads multiple councils. The Link Academic Affairs Council is represented by the associate deans who are responsible for the curriculum in all 5 schools. So these are administrative leaders coming together to make joint decisions about IPE through this council. Our faculty council are representative faculty members who have been put forward by their schools to lead the development of IPE activities and to help advance IPE on our campus. We have a student council with representatives from each program, and we have an assessment council with the assessment experts from each school who are coming together to help us measure our outcomes and help us get a sense of how we need to improve our activities. One case study I want to share with you is the common IPE experience at UT Health San Antonio. We decided within our Academic Affairs Council that we wanted to develop a shared IPE activity for all students at UT Health San Antonio. We wanted to start with incoming students. It was going to be classroom-based. We were going to focus on interprofessional socialization. And the idea would be that starting on day one, we would help these students develop mutual trust and respect for one another so that they could continue to develop skills for IPE. We were going to build 2 classroom-based activities and 1 simulation-based activity. That was going to be the basis of our common IPE experience. And we were going to focus on the scientific underpinnings of interprofessional teamwork as our content. As you all know, COVID-19 put to rest all of our best laid plans. We went back to our organizational structure and basically said, should we throw up our hands? Should we wait for COVID to pass? Or should we build something of substance for our students? And that's exactly what we decided to do. We went back to our roadmap, which is the Hpac guidance, and we said, okay, if we can't do in-person learning and we can't do simulation-based learning, what can we build via collaborative online learning mechanisms? And what we decided to do was to launch a pilot this spring, and then to take lessons learned from that pilot to roll out a large-scale university-wide IPE initiative that starts on September 1st, just in a few short weeks. We led our pilot, and this is a broad poster. Obviously, you're not going to be able to read this, but it is currently being presented at the National Center for IPE's annual meeting. This pilot involved essentially us pulling students together through our online learning platform. We developed an illustrated case that was based on a community member's story. This is our community member. Her name is Lakeisha Johnson. She has a personal story where she and her husband adopted a child with very intense health needs. And we built a series of case studies around their family's experience. Some of those cases are illustrated cases. Some of those cases are video interviews with stakeholders in this child's life. And we presented those cases to our students. You see a speech language pathology student here, a physical therapy student there, and a physician assistant student here. They work through these cases at their own pace through our online platform. And we had 30 students run through this pilot across all 5 of our schools. We measured whether they were able to engage through our online platform, whether they found value and meaning in our case study approach. And what you see through our pilot results here are very high scores on engagement and value and applicability through the online learning. We also broke down qualitative feedback, and we learned that they liked the small group format. They were able to engage. They enjoyed interacting and learning from students from other professions. However, some of the students did not feel like they were adequately represented in any of the cases that they worked through. So we took that feedback and we built new cases to basically expand the number of professions and scientists who were who were included and represented in these cases. So starting September 1st, we are launching 3 online modules focused on interprofessional socialization. There will be roughly 1,100 students who complete these 3 modules in interprofessional groups of 3. And we're maximizing flexibility by allowing them to complete this activity at times of their choosing from September 1st to October 31st. And we are measuring and assessing finite elements of this experience in order to not only publish our results, but so that others can learn from our experiences, but also to refine and improve for the future. So I will close with a quick summary that basically shares with you that IPE has become something of critical importance to the US healthcare system. And pharmacists are absolutely critical pieces to the delivery of high quality care, but pharmacy educators shaping and advancing IPE are indispensable to the progress that's happened in our country over the last decade. The big 3 in the US gave us a common language, and they gave us a roadmap on how to do this. And some of the common language and some of that roadmap could very well be applicable to the work that you're doing in Iraq and throughout the Middle East. And the last thing I would close with is a statement that COVID created a lot of disruption and basically turned on its head all of the historical best practices for IPE, which involved in-person, face-to-face learning. And in some institutions basically shut down IPE. Others took it as an opportunity to say, maybe this could be an area where we could innovate and advance. I'm very happy that at our institution, we chose it as an opportunity to try new things. And I would encourage you all to do the same as you work to advance IPE on your campuses. So with that, I'd like to just say thank you again for the invitation. I hope that this talk sort of laid the groundwork for why IPE is critically important for healthcare, but in particular for pharmacy and pharmacy education. And I'd be happy to take some questions.
Thank you very much, Dr. Zorek, for this nice and informative talk. I will leave you with Dr. Mohammed, my colleague, in order to run the question and answer session. Assistant Professor Dr. Mohammed Mahmoud completed his PhD in clinical pharmacy in 2014 from the College of Pharmacy, University of Baghdad, and currently he is the head of the clinical pharmacy department at the College of Pharmacy, Mustansiriya University. Dr. Mohammed, you can take control over a Q&A session with Dr. Zorek.
Okay, thank you, Dr. Athmara, and thank you again, Dr. Zorek, for this rich talk. There are some questions from the audience. I will start with the first one about the potential barriers to reach the optimum IPE. This may include some professional health, lack of some professional health programs on campus, or maybe unmotivated curriculum structure, or the lack of perceived benefit from IPE. I think it's need more training and more institutional support. How could we overcome this obstacle?
You know, that's a great question, and these are all obstacles that exist throughout the globe. And you know, one of the things I like to share with folks is that, well, I laid out the framework for Ipe, the National Center, and Hpac, because those 3 entities basically demonstrated, they set the tone at a national level for all constituents that IPE needs to be taken seriously, and that there are important implications for the lack of coordination and collaboration. So, you know, it begins with leadership coming together and building relationships and setting the tone for all of their constituents in their respective programs. But essentially, the key feature for success in building IPE is relationship building. And so to go from having no IPE to having very robust multiple activities integrated into a curriculum, that's not necessarily the best approach from go from 0 to 60 like that. The best approach is to start small and to build small pilots and to start with the willing. And so I would encourage anyone who wants to advance IPE to start to find a partner in other programs and to share with that, to build a small pilot. It could be a pilot IPE activity with 30 students. It could be a pilot IPE activity with 5 students. But if you develop that activity with a willing partner in another profession and you measure outcomes and you have those outcomes to share with administrators and leaders who have decision-making authority, that's the process that has to start. It starts small, but the more data-driven you can be, and the more you start small and build on small successes, one on top of the other, that's how real transformation happens. So I would say to you, at our institution, there's no way I could have come to our institution in 2019 and on day one said, we're going to do IPE for 1,100 learners 1 year from now. That just was not practical. We needed to take time to build relationships across programs. We needed to build consensus and a shared vision for what we wanted this to look like. And importantly, we needed to pilot what we were doing. And so the pilot project that I shared, it had 30 students in it. Clearly, we cannot generalize to 1,100 students. We don't know that the 1,100 students who are going to complete our Common IP experience are going to have the same experiences as those 30 students. However, the seriousness with which we took our pilot and the sort of fierceness that we advocated within all of our programs for using that data, that really helped us build consensus and create buy-in so that we could launch this activity for the future. So, in summary, I think you have to start small, you have to measure what you're doing, and you have to use that data to influence decision makers.
Okay, thank you. It's worthy to hard work to get this goal. Okay, another question. How could you provide feedback about interprofessional collaboration to support and enrich the interprofessional practice for learners?
So can you repeat that question? I'm sorry, I didn't understand.
Okay, how could we provide feedback about interprofessional collaboration to support and enrich the interprofessional practice and learners?
Yeah, and I think the question, if I understand correctly, is how do we characterize and describe the interprofessional collaborative practice environment in order to use that description to inform and advance educational activities. Again, I would say data is important in the health professions. And so one of the slides that I shared was a clinical IPE activity. That was the geriatric assessment clinic where we had the PharmD resident and the PharmD student and the medical student working directly with patients. That clinic started as a very small pilot and we measured outcomes. So and we published those outcomes. And so one of the things that we were measuring and that we were publishing were changes in preventive care services. So one of the things that a lot of older adults are recommended to get are a whole host of screenings and vaccinations, for example. We basically measured how up to date our patients were in a whole host of preventive care measures. So we were able to show that our clinic and the clinical IPE activities happening inside that clinic were influencing health outcomes. And they were not large. We weren't measuring morbidity and mortality. We were measuring simple adherence to preventive care services. But that data was strong enough to convince leaders within that clinic to expand that clinic and to grow services. And we went from a clinical environment where there was a lot of skepticism around collaboration, even in the clinic, to now a sense of acceptance that this is of high value. Collaboration with pharmacists and pharmacy students and residents is of high value. So I would say there are countless examples of that also in the published literature. And so collecting data on the impact of collaborative practice on patients and families and communities and sharing that data with key decision makers, I would say, is the best way to convince folks that there is value. And again, it has to start small. You have to start with what you can do. And if you're in an environment where there's a large reluctance to collaborate in that fashion, you basically just have to find an area and a partner and then create that partnership and measure the outcomes of the collaboration.
Okay, thanks. This question from Dr. Kauthar Ahmed. Would you recommend applying IPE for juniors or senior students if applying it for all level is not feasible?
That's a great question. I think I would repeat my previous answer, which is I would recommend applying it wherever you can. So when you're first starting to build an IPE program, it has to start with a coalition of the willing. Who is willing to do IPE? And so if you find a partner in medicine or in nursing or in physical therapy, and they want to partner with you, I would create that partnership in a way that would make that pilot successful. Oftentimes it's easiest to start with the earliest learners because they're new, they haven't been biased, they're open, they're energetic, they're not tired because we've overworked them in our curriculum. They're not tired yet. And so a lot of times I like to start with early learners because you can start with easy concepts. You can start with lower level learning outcomes. Things like changing their attitudes or their perceptions. If you start with later learners, oftentimes the measuring that you do in IPE is focused on collaborative behavior, things that are harder to measure and to influence. But again, I would start wherever you can, and I would partner up in whatever way there was a possibility.
All right. I have time for one more question. What are the best practices for interprofessional group facilitation, and what are the standards for good facilitator for IPE?
And that's a great question. Best practices is a term I try to shy away from, but I would say things that are meaningful for facilitators is ensuring that the facilitators that you recruit to deliver IPE activities, oftentimes we don't put enough energy into training those facilitators. And so a lot of times in IPE, because we need a lot of facilitators to do large scale in-person learning, for example, oftentimes faculty members join very late. They have not been adequately trained or prepared, and we end up with suboptimal facilitation. And so what I would recommend is that one of the key components when you're in the planning phase of an IPE activity, one of the key components that should not be ignored is the creation of a facilitator guide and training sessions for facilitators to make sure that all facilitators understand what is trying to be accomplished and how to work with one another when they come together to facilitate those activities.
Okay. Thank you very much, Dr. Zorek. It was a great information, and I will go back to my colleague, Dr. Atmar. Thank you.
Thank you.
Thank you very much, Dr. Zorek, for this lecture and for answering the questions and for joining us today at our conference. Our second speaker of the day is Professor Nasser Al-Sharif. Professor Nasser? Professor Al-Sharif, are you with us? I'll introduce Professor Al-Sharif. Professor Nasser Al-Sharif, a PharmD and a PhD. Dr. Al-Sharif received his PharmD degree from the University of Nebraska Medical Center in 1987, followed by a master from the same university in 1988. He received his PhD from Creighton University Medical Center in 1992. He joined Creighton University Medical Center in 1994 and is currently a full professor of pharmacy sciences and a coordinator of International Program Middle East and India at the School of Pharmacy and Health Profession, Creighton University. Dr. Al-Sharif served as an associate director of the distance pharmacy pathway from 2001 to 2006. He was acknowledged by receiving several awards, to name few, winning an Outstanding Teacher Award and Scholarly Teaching and Service Award. Dr. Al-Sharif published several articles, abstracts, and presented nationally and internationally in the area of his expertise. Welcome, Dr. Al-Sharif, and thank you very much for joining us today. We are looking forward to hear from you. The screen is yours, and you can start sharing your slides.
Thank you very much. Can you all hear me? Can you all hear me?
Yes, we can hear you. We can hear you loud and clear.
مساء الخير, السلام عليكم, يعطيكم العافية. I want to thank you very much, Dr. Munzer, Dr. In'am, Dr. Mohammed Mahmoud, for the invitation. Thank you all for being with us. Thank you for the previous speakers. I had the chance to listen to most of the presentations, and as you will see, hopefully with my presentation, there will be a lot of complementary information related to what they discussed and hopefully what you're trying to accomplish with this conference. It is always such an honor to present to colleagues in the Arab world, certainly in Iraq. Iraq is the cradle of civilization. I read about your university, and it's amazing to think about Muslim Sharia University that you are established in 1227. I mean, that is unbelievable, almost 800 years ago. So that is wonderful, and it's such a great pleasure to be presenting to you and again to colleagues in Iraq. There is something special about your university in a way. I happen to be a Palestinian, and I saw that you are actually located on Palestine Street. Is that correct? Yes, thank you. And
yes, it's correct.
In fact, there are Jaffa and Haifa streets right next to you. So I feel like I'm back home. So again, thank you very much for inviting me. As I mentioned with my title, hopefully we'll be touching a lot of the information that was discussed earlier by Dr. Mark, Dr. Gloria, Dr. Joseph that just finished. And I'm happy to also be with my colleague, Dr. Mohammed Rahal, and he will also kind of share some really good information, especially with the COVID and what's happening and how can we really in those challenges still be creative, innovative, and so on. So very excited to be here and be with you. Please keep kind of this polling address closely with you, maybe access the website. I'm going to try to do some interactivity. Hopefully it will work. We'll see how that goes. So keep that in mind. all the time and kind of access the website, poolev.com, Nasser Al-Sharu 141. So if you can access it now, that'll be great, and hopefully we'll be able to do some interactivity. Our objective for today is to define what we mean by disruptive innovation. Some of you might have heard this term. It was actually coined in the business kind of setting, but we'll talk about it from the perspective of higher education and certainly pharmacy education. Identify what are barriers for innovation. You just listen to Dr. Joseph talking about IPE, which is certainly a very creative way in terms of showing the value of pharmacists as part of a healthcare team. So we'll talk about some of these innovation. We're going to address the requirements for innovation in pharmacy education, and we'll also touch on pharmacy practice too. So that will be another key thing we will be discussing. Some of you might have great examples for what's happening in Iraq, what's happening in other Arab countries and so on. And I'll provide some examples to also emphasize the innovation. We'll also look at what are future opportunities for innovation in pharmacy. And I also want to make sure that the same thing as Dr. Joseph mentioned, a lot of things that could happen in the United States or in Palestine or in Iraq and so on, those are very specific to each one of us based on the practice opportunities, the barriers that might exist, the healthcare system and so on. So again, when we discuss some examples, whether from the United States and so on, I hope you keep in mind, think what are the things that are possible for us at Al-Mustansiriya University, at the College of Pharmacy in Iraq, and certainly in the region, in collaboration with countries next to you, whether it's Lebanon, again, Mohammed Rahal will be with you and so on, or other countries that are in the surrounding region in terms of optimizing pharmacy and pharmacy practice and pharmacy education in general. So keep that in mind, please, as we discuss. I'm very proud to be presenting and somewhat representing the Arab American pharmacy educators. These are a amazing group of faculty members, educators, both in the United States and in the Arab world. And they have really accomplished so much, and we've been in existence for the last 3 years. And our mission is to advance pharmacy education by promoting collaborative approach to teaching, practice, and scholarship, and to really respect, again, the perspective of pharmacy education and practice in the countries, depending on what is existing, again, in Iraq, in Syria, and Lebanon, and so on, keeping that in mind. So that is really important and critical. Our values to conduct ourselves in the most ethical, respectful way, and respecting the diversity, being innovative. That's the topic of this presentation, showing leadership in everything we do, and also the commitment to really improve quality education, pharmacy education, and so on, all over the world, certainly in the Arab world, since many of us have either been born there or have come to the United States, but we still have our roots there. So that's really critical. So I'm going to try the first kind of interactive. Hopefully it will work. So let's see how that works. So please access the poll. Do you see my screen? Can you see my screen now?
Yes, yes.
All right, so here we go. That's the first question. Where is Omaha, Nebraska? This is the map of the United States. So go ahead and just point once you see, are you able to see it on your screen? Hopefully people are participating. I don't see anything so far, so. Are you able to access the website? Maybe the panelists, I would love to see an arrow showing on the screen anytime, no? Maybe it's not gonna work internationally. I was told that it should work. That's why I tried it, but in any case. It doesn't look like it's going to work. Well, we'll see how that. All right, let me go back to my presentation. Omaha, Nebraska, this is the United States. If you put your finger almost right in the middle of the United States, right here, that's where Omaha, Nebraska. This is the state of Nebraska, this is Iowa, this is Kansas, and we're right on the border there. Creighton University is about like 2 minutes drive from the state of Iowa. So that is Iowa. Again, I'm going to try this. I really hope it will work. Let's see if this works. All right, let's see here. Or you know what, maybe for the sake of time, let's not try. I was afraid this might not work, but okay. Maybe in the chat, let's try to do this in the chat. Can you write one word that come to your mind about the image of pharmacy in Iraq? So please use the chat. That way we'll at least have some kind of idea in terms of. So please go ahead and type, what is the image of pharmacy in Iraq? Creative, thank you. Go ahead. Dr. Rahal, thank you very much for participating. My goodness, we have 270 participants and I only got one answer. This sounds like a classroom with students. Chaotic, wow. I would like to hear from you, Dr. Yasser. Dispensers, progressive. So at both ends, progressive, dispensers. Large number, absolutely, that's happening everywhere, even in the United States. Copy it. Dr. Sardar, so like copy, I'm not sure what you mean by that. Maybe you're copying things from others, communicator, competitive, less utilized. Oh, absolutely, yes, need a lot of improvement, accumulative, developing. So we'll stop here for the sake of time. Thank you very much for sharing, and I apologize the poll is not working the way it should be. But this is, I thought if it's not going to work, we're going to do it this way. Excellent, thank you. And you can see the wide range where people feel it's progressive, it's creative, innovative, but then people saying there needs to be a lot of improvement. There's a lot of pharmacists and so on. Thank you very much. Next one, write one word that come to your mind about pharmacy education in Iraq. Go ahead, please. One word that come to your mind about pharmacy education in Iraq. Varies, absolutely. That's the same in many countries, depending on the university and so on. Fighting, I'm not sure what you meant by that. Hopefully there is more collaborative kind of mutual respect among a lot of information, not so collaborative, different expertise, theoretical, not beneficial, passive, many new schools, that's the same for many schools. The passive also, that applies for, even here in the United States, there's some, in even the same institution where there's passive learning rather than active learning, many new schools, absolutely same thing in the United States. We ended up from 80 schools to 144, I believe now, commercial. There is private schools everywhere now, but hopefully they're still maintaining quality, theoretical rather than practical. Thank you. Again, you guys are capturing unbelievable, the wide spectrum, absolutely. And thank you very much. Under ambition, thank you very much. How about pharmacy practice? Give me some words about pharmacy practice that come to your mind. Cost is high. That the healthcare system, are you saying that the cost is high? Is that what you're saying? No practice at all. Ooh, I hate to hear that, Dr. Anas, but maybe you can share with us why you feel that way. Not enough dispensing, okay? insufficient clinical training, thank you. Poor, not well known, selling medications only. So dispensers or pill dispensers, that's the image, we'll talk about that. But that exists in many parts of the world. Only distribution of drugs in hospital. All right, we'll stop here. Again, a wide range in terms of what people feel in terms of pharmacy practice. But this is really important, very, very important. If we want to disrupt the status quo in terms of pharmacy, whether it's education, practice, or any aspect of what we do, we need to know what people feel, especially those that are in the profession. So we need to make sure we know that. Okay, write 1 or 2 words which define disruptive innovation, which is the topic of this presentation. What do you think is disruptive innovation? You could use 1 word or 2 words. Go ahead, please. It might be difficult for some people because maybe you haven't heard the term, but what do you think when we say disruptive innovation? Dr. Joseph just finished his presentation and he said, COVID was a major disruptor. So total change, wow. Okay, we'll talk about that, Dr. Athmar, whether we want total change or what is it we're looking for. Thank you. Thinking out of the box. Thank you, Dr. Ahmed. Excellent. Radical change. That's also a good one. But again, I have my reservation and you'll see what I mean by that. Positive change. Excellent. Very good. Again, we could go on and on with this, but I appreciate you. So keep those things in mind, and maybe some of you that have not answered, reflect on those, and hopefully will be helpful. Now, please just write A, B, or C, or D. Whose vision is represented on the screen? I hope you can read that. أن تكون مركزاً تعليمياً يزدهر في رحابها العقل وتعلو فيه قدرة الإبداع والابتكار. And I love that, الإبداع والابتكار, which is the title of this presentation. وأن تتوافق مناهجها الدراسية وبرامجها التدريبية مع أحدث المناهج المعتمدة في كليات الصيدلة العالمية. Which one is it? University of Baghdad, Creighton University, Al Mustansiriya University College of Pharmacy, the Lebanese International University College of Pharmacy. Dr. Sardar said C, D, D. I see A, C, A, C, C. All right. Well, believe it or not, that's from the website of Al Mustansiriya University. So for those faculty that teach there, and they answer anything other than C, that's not good. That is, you're actually the vision of your university. So, and the reason I put that is this keywords, al-ibda' wal-ibtikar. I will bet you most universities, including Creighton University, have something to that respect, but that is what is written in terms of your school. A college. So very, very important that we all really think about, again, al-ibda' and so on. Another key thing that I'm going to be discussing, which is kind of a lot of what we need to think about, is yes, you just talked about interprofessional education. I also emphasize intra-professional sensitivity in pharmacy education, and that goes for practice. So please take a minute to read the answers and write your answer. What do you think is intra-professional sensitivity in pharmacy education? What is that about? And I'll explain throughout the presentation why is that important for disruptive innovation. Go ahead, please. Read it. I'll give you a second, and we'll go ahead and I see C, I see A, C, A, D, C, A. Wow, a lot of A's. I couldn't catch it. I'm not sure what Dr. Milad means by that. AAA. All right, we'll stop here. It looks like the consensus is A. A lot of people might think that is the case, but in fact, intra as compared to inter, it is within the profession. So within the pharmacy profession, not with other healthcare professionals. So the real answer really is to be sensitized to the role of basic science, clinical science, and social and administrative science faculty play in the education of pharmacy students. How we as pharmacy educators show respect and understanding, collaboration with each other, ultimately to optimize the education of our students, or how we as pharmacy practitioners respect the role all of us play in, again, optimizing our patient care. So please keep that in mind, because I always say if we do not first respect ourselves as a profession, students, faculty, administrators, practitioners, regulators, all the people that are part of our profession, we have to clean our house first before we venture out and try to reach out other healthcare professionals. Don't take me wrong, IPE, what was discussed with Dr. Joseph, is so critical, but we really have to clean our house first and optimize our house in education and in practice to really make a difference ultimately in the kind of graduate we will have, but also in the kind of practitioner that we have. So I want to keep that in mind, because that is something that I strongly believe in, and our role in terms of how we respect and collaborate with each other, and the role that each one of us play is so critical, so critical. So with that, let's kind of talk about some definitions. Again, disruptive innovation. This is a term that was coined in the 1990s in business by a professor. His name is Clayton Christensen, and he wrote so many books and articles about it. And it's an innovation that helps create a new market and value network that eventually disrupts existing products and services, which means you could have a small company that starts, and that small company doesn't have any kind of chunk of the market, but all of a sudden they keep moving up, and all of a sudden they take over that business and they disrupt that whole industry. So that is really what was coined in business. And we'll talk about what is needed when we think about pharmacy. So certainly higher education and pharmacy and so on, we need to really make sure that we also are disruptive in terms of how we do our education, thinking about, how can we control that disruption as we move forward, and the same thing with our practicing, our practice of pharmacy. So very, very important. Another aspect of that is entrepreneurship. These are the behaviors that lead to new and creative use of resources. Again, how we as pharmacy educators use our resources that are available for us to produce the best graduate. How do we do that? How can we be creative to do that? Entrepreneurship in doing that. And the same thing for pharmacy practitioners. And how do we have that orientation to do this, to embody the processes and requirements, as well as the intentions and behaviors for what is needed in our marketplace, whether it's in pharmacy education or pharmacy practice. So these are really, really important. And certainly higher education, pharmacy education, we need to make sure we are being creative. But a key difference is in higher education and in health professions, we're not trying to displace anybody. We're not trying to extinguish anybody. I share this because my first paper in pharmacy education was about what is care in pharmaceutical care. When that came about and we had the PharmD degree, quote unquote, displacing the BS degree, we alienated the bachelor pharmacists as if they are no longer important. when in fact, many of the bachelor pharmacists, the BS pharmacists, are the ones that really brought us to the era of clinical pharmacy. So we need to respect the past. We need to respect what the past have given us, even the dispensing kind of aspect of what we do. That is also very important. It's an art. So the care in pharmaceutical care is about caring for each other, caring for the BS pharmacists, caring for the pharmacy interns, pharmacy technicians, all the people that are part of our education and practice, so that we all move forward together. Basic science faculty work together with clinical faculty, with social administrative faculty. So we need to care for each other to move forward. So it's not about displacing or extinguishing or getting rid of people or institutions. It's really how can we work together. So again, I want to emphasize that as much as possible. There are many barriers, whether in the United States or any country related to innovation in pharmacy education and the pharmacy profession. Certainly the curriculum is a major aspect of that. If the curriculum is stagnant, it's not really looking at what's happening in practice and so on, it's not going to help in being creative, innovative, and producing creative, innovative graduates and so on. What is the existing culture? If you have an institution that has been around for 100 years and your institution, the pharmacy school started much later, but again, when you have an existing culture, how do you change that culture to be more innovative, creative, and in line with what's happening in real life, in the profession, and so on? Very, very important. If there is no leadership or champions, whether again in education or in practice, that's gonna hinder our ability to innovate and so on. So we need leaders. We need our students to be leaders and so on. Inadequate education and training, certainly that was mentioned in some of the answers for some of the questions that I mentioned. So we need the appropriate education and training. And major one, and that happens here in the United States, that happens with graduates in the Arab world that travel to many countries, and there is this illusion about pharmacy and pharmacy practice and opportunities and their self-identity as a pharmacist. If that continues to exist, whether here in the United States or other parts of the world, then our practitioners are not going to be creative and innovative because they feel, what are the opportunities out there? What am I going to do? I'm going to be, like we say, باللغة العربية بقال. I'm just a beer, that's it, or dispenser of medication and so on. So again, how can we change that kind of self-identity to be proud and confident of the knowledge and so on? There is no partnership between academia and practice or healthcare systems. That is really critical and important. How can we do that? Participation, appreciation for the role of the current pharmacist and the role they can play, as you saw in the United States, in other countries, in the Gulf, the United Arab Emirates, Qatar, Oman, Egypt, Lebanon. There is so many creative ways that pharmacists have been able, but we need to advertise that. We need the public to know. We need the health insurance system to know and so on. So we need to work on that a lot more. The job opportunities are always going to be an issue. So how can we expand the job opportunities? The financial is always critical because pharmacists need to be paid for these cognitive abilities that they have and helping patients in different ways. So if there is no incentives for that, sadly, they might resort back to just being dispensers. And that's not what we want. So that is really very, very critical and so on. Pharmacists everywhere have time constraints. So how can we allow them to have the time to really innovate, be creative? And same thing for educators and so on, so that they're able to really think about what's the best way to help their students in terms of the knowledge with active learning and critical thinking and all the stuff we try to advocate in terms of educational outcomes. If we have rigid regulations or accreditation standards that doesn't allow innovation, creativity in how we conduct ourselves in academia or in practice and so on. The scope of practice of pharmacists, very important. How can we expand on that so that pharmacists are able to do other kind of jobs that are not being met by other healthcare professionals? And that's how our innovative thinking always should be. How can we fill the gap in terms of certain kind of jobs or skills that are needed by society, but they're not being met by other healthcare professionals? How do we address the resistance by other healthcare professionals or organizations? The role of the pharmacist in a community setting, in an ambulatory setting, in a hospital setting. How can we get the physicians to work collaboratively with us to make sure that they appreciate what we do? So these are all kind of things we need to address, and we'll touch on those as we go through the presentation. Now, in terms of Christensen and his colleagues, they put this 5-step process for this disruptive innovation in business. And I think they do apply for us in pharmacy or other settings. Associating, somebody said, we need to think out of the box. Yes, we need to get out of our own bubble in pharmacy. Look at what other disciplines have done, how successful they are. In the United States, nurse practitioners, physician assistants have been able to really establish themselves as part of the healthcare systems. So how can we do that ourselves in pharmacy, in Iraq, in Lebanon, in Jordan, Palestine, and so on? Very, very important. What questions do we ask? Who are the people that we need to really move kind of forward to really help us to achieve these things? How do we ask the why question? Why not? Why should we not do this? To be really more kind of willing to create and so on. What if we do this, what's going to happen? What we need to do and so on. So always trying to challenge the status quo. Very, very important. We need to be observing what's happening around us. What is the role of all the stakeholders, the Ministry of Education, the Ministry of Labor, the Ministry of Health? How can we meet those needs that they are kind of needing and so on? In education, what is the role of IPE? Again, intra-professional sensitivity. How do we work with each other's in pharmacy education, in pharmacy practice, and so on? How do we experiment? Are we willing, again, to get out of our own box and think about continuous quality improvement, assessment, whether it's in the education, closing the loop based on indicators of quality and so on, having purposeful assessment, again, that closes the loop and help us finding trends and moving forward and so on with what we're trying to accomplish. And finally, networking among ourselves as educators, among practitioners, among institutions. I apologize, I was going to check how many pharmacy institutions there is in Iraq. It's so key that all of you get together and try to work collaboratively to see what can be done for pharmacy education in Iraq, regionally with countries in the Arab world to see what can be done. And certainly practitioners, again, there's great practice models all over the Arab world. How can those practitioners work with each other, collaborate with each other in an intra-professional, sensitive way to really optimize pharmacy practice and so on? So these are 5 critical steps in doing this. A lot of the stuff that I'm going to discuss now, kind of I touched on, but let's take it again in terms of, and now we know some of the barriers or some of the issues and so on. So what is our role? What is our role in education? Certainly it starts with the admissions process. We all understand the financial burdens on universities and so on, but how can we look beyond the numbers, the quotas that we need for enrollment? How can we look for new students that coming in that are creative, innovators, committed to the pharmacy practice and so on, that there will be leaders and innovators. So our admission process, how can we change that to really optimize that? Medicine do that, physical therapy, other dentistry and so on. So is there a way to really, when the pipeline with the people coming in, can we really find a way to find the students that identify themselves with pharmacy and they are going to be taking pharmacy to the next level of practice and so on. Didactic coursework, what do we need? We need, of course, the knowledge, the skills, and the right attitude. Many times we don't emphasize the right attitudes that the students need to have moving forward and so on. How can we make them innovative thinkers? And again, the innovation, the entrepreneurial orientation, and to think about different models for practice and so on, and critical thinkers. Very, very important. How can they exhibit the behavioral characteristics before they graduate? We talk about professionalism. So what is their commitment to really exhibit the characteristics we expect of them when they graduate, and to have a self-identity as a pharmacist that respect the profession and want to move the profession to higher level. Again, you heard about a lot of these things, the experiential experience. Dr. Gloria talked about that yesterday, and you talked about quality education. Mike mentioned about what is change without quality. Everything we do didactically and experientially, it needs to keep quality in mind, and how do we do it with quality and so on. Very important. Residency training, many parts of the Arab world are now starting residency training and also getting accreditation by ASHP in doing so. But again, how do you establish your own quality in the training of your graduates and so on, and based on the regional or national kind of needs of Iraq and so on, is so critical, so important. Graduate training, I saw that you have a master's program, and some of your students on your website were defending their master theses. Fantastic. We need more graduate training, and students that are in drug delivery and clinical research and all kind of research. That is so important, and to be creative, innovative in those and so on. But also, what are the job opportunities for our graduates, whether it's in academia, in practice? We need to always be, as educators, thinking about how can we have them ready for those job opportunities, or for them to create new job opportunities. Very important. Another key thing I always emphasize for us as educators, when we do something and it works in education, we need to publish it. We need to show that what we do is evidence-based. The same thing with practice, clinical practice. It should be evidence-based. Same thing with what we do. And the more we do that, we improve on the education all across Iraq, all across the world, because whatever instructional methodology we use, and we investigated that in a scientific way and so on, and share it based on a scholarship of teaching and learning, that is going to help us also. Very important, very critical. Graduate education training, again, dual degrees, that's very common now in the United States. About 20, sometimes 30% of our students graduate with a PharmD and a master's in business administration, in public health, and some other degrees. And we need to create those opportunities and be creative and innovative so that we kind of innovate our profession even more. And again, I cannot overemphasize intra-professional sensitivity. That is so critical, so important as we do anything in academia and in practice. Continuing again with requirements for innovation, role of individual pharmacy student, pharmacist, that is very important. I talked about the self-identity and pride in pharmacy. That has to be key aspect of what we do for both our students, but also the pharmacy practitioners. So God willing, we rise and uplift the profession to higher levels. Very, very important. We kind of talked about the institution, the education, and what is needed. Professional organizations, so critical. And when we say professional organization, we need pharmacy organization to be more aligned with the profession. Politics and other things should not be part of that. Advocacy should be part of that to improve the profession. That is so critical. But they also need to play a role in the image of pharmacy, how the image of pharmacy is portrayed in the social media, what people kind of know about pharmacy as a profession. Is it a pill dispensers? It is the dispensing image, or what else? I always, whenever I present this, I always say you need to find somebody in your country that make a difference. I love Chasm, and maybe Chasm needs to have a beautiful song about what pharmacists do in society in terms of optimizing healthcare. And maybe people say, wow, if Chasm believe in that, maybe we all should believe in that pharmacy has a role in healthcare and patient care and so on. How do we work again with the Ministry of Health, Labor, Education to really make sure that pharmacy is respected, there is job opportunities, there's increase in the scope of practice and so on. All of that, there's more flexibility in education, in the regulation that are imposed on pharmacy schools and so on, to really create innovative kind of ways to do things and so on. And again, how do we understand the healthcare system in Iraq, and how do we work with that healthcare system, insurance companies, private and so on, and others, to really optimize the healthcare? How do we create interprofessional opportunities for practice and for pharmacists to be paid for being part of an IPE team and so on? Very, very, very important. And of course, in the United States, we use technicians, and many of them are certified. How can we expand their roles so that the pharmacists can really do many of the other functions that are critical and so on for innovating and finding ways to innovate? In terms of the pharmacy setting, the practice setting, pharmacists need to have the resources to be able to innovate. Certainly technology, robotics can play a role there, other things. They need to have the latitude and the time to be able to, to create and innovate. There is incentives. Some countries have already started that. In England, depending on what pharmacists can provide in terms of services, they get payments for those services with medication therapy management and other things that they incorporate as part of their services. Piloting the services. Pharmacists need to be creative in terms of creating new ways to educate patients in their community. Anticoagulant clinics, wellness clinics. There's so many things that are happening in the United States and other countries. And again, how do you document? When you do anything that shows outcome, positive outcome for the patient, how do we document this? The whole clinical pharmacy in the United States really would not have happened if there was no documentation of what pharmacists can do, whether it is the things that were done at the University of Minnesota and how inpatient pharmacists contributed to patient safety and changing, modifying therapy and saving money in terms of the treatment. All of those kind of studies were so critical. Or in an ambulatory setting where pharmacists were involved with patients with asthma, and they showed how when they become involved, pharmacists can decrease the number of times that the patient with asthma ends up in the emergency room and so on. And the United States, going to the emergency room is a major cost. So when the pharmacists were involved and they taught the patient about how they use the inhalers and so there are many studies. So my goal here is we might not be paid at one point or another for what we do, but the more we document what we do and share it, and that is really going to be critical. And developing new practice models and creating new job opportunities is a major, major aspect of that. Kind of shifting gear, going back to the education. And again, the key thing with that is accrediting bodies and what they advocate in the United States, talking about one of the barriers, a stagnant curriculum. ACPE and Standard 10 talks about the curriculum. It's a major one. We're going through a self-study and we're working on our kind of curriculum and to show that it is innovative, that we have expected outcomes for our students, that we have sequencing of our curriculum so that we introduce things, we reinforce them, we ask the students to demonstrate. So there's great ways of vertical and horizontal kind of integration of the content for the students to really have a good learning experience, and to show that we're creative in the way we teach in terms of our instructional methodology, active learning, assessments, and again, the experiential experience, whether it's the Ipes or Appes, the advanced pharmacy practice experience, that they're providing the students with what they need. And with all of that, how do we assess that the curriculum is meeting these educational outcomes? That is something that all pharmacy schools, all health professions are trying to do. And it is part of our standards, which makes it critical, important that we do. So again, the educational process from the accrediting body in the United States should promote lifelong learning. That is very important, and active self-directed learning. So that is something we need to do in our curriculum, which makes us having to be creative, innovative. Also, our students have to be critical thinkers and problem solvers. So again, they have to stand on their own in the classroom, but in the clinics, in their training, and ultimately when they practice. Very, very, very important. In the United States, believe it or not, in the 1950s, pharmacists were not allowed to speak to patients. That was the law. But things have changed. I started with the Mills Commission, where they identified the pharmacists as drug information providers. That is by itself an innovation, creativity in terms of what the role of the pharmacist. They emphasize communication skills. Again, 4 years before, the pharmacists were not even allowed to speak to the patients and so on. And of course, the concept of pharmaceutical care. The Institute of Medicine, Dr. Joseph talked about IPE. The Institute of Medicine in 2002 published a bridge to quality, and that's where interprofessional education was really emphasized, where pharmacists need to work with other healthcare professionals as part of the healthcare team. Evidence-based practice was critical and so on, very important. There was a publication by the American Association of Colleges of Pharmacy, and they also looked at the importance of experiential experience, the importance of educational outcomes. So all of that really helped to innovate what people do in pharmacy education. And that is, again, a key aspect ultimately to what might happen in practice. So it goes both hands in hand and so on. What are the qualification of the clinical faculty to, again, help the students get the experiential experience that is needed? Very, very important. There are things that they also looked at that are external to pharmacy. Again, the Institute of Medicine and the competencies, Dr. Joseph talked about that and what pharmacists should have in terms of competencies as part of a healthcare team. We have diversity of schools here in the United States, and there is new schools opening. Now we kind of have a limit almost on how many can exist and so on, but concern about the quality of the practice sites and so on. And now we're seeing more and more distance education. Of course, COVID had made that something that we have to do. It's a must. Believe it or not, when Dr. Mike talked about the one school that started in 2000 and had a full-blown pharmacy cohort that is studying at a distance, that is my university, Creighton University, our School of Pharmacy, and we have graduated so far 19 classes in distance with about 70 to 80 students in the distance pathway, and they do as well and sometimes better on the national exams and so on. So distance education is an innovation and it can be done. And again, with COVID, certainly that became a must for a lot of us. Assessment became very critical, very important. If we want to innovate, we need to always assess what we do and how we do it and so on. Other things that came that I believe are innovation because it created job opportunities for pharmacists, emphasis on patient safety, public health. Now we have pharmacists working as wellness coaches in all aspects, smoking cessation and other kind of health issues and so on. Very, very, very important. So very critical. Whether you talk about FIB, UNESCO, or the World Health Organization, all of them recognize that there is a need for innovations and training pharmacists to help with the workforce, that they should be competent and committed and able to work in whatever setting in Iraq and so on, or any other country based on competencies that they have. UNESCO always emphasized that higher education has a major role to play to advance cooperation and exchange of ideas and so on. So we need to do that. In the United States, interesting enough, a major factor now is higher education is under major scrutiny, and how the value of higher education is really worth the amount of money that our students pay. So there is great pressure on us to prove that the education they get at Creighton University or any other institution is definitely of value and so on. Again, the global pharmacy education, World Health Organization talk about shortage of 4 million healthcare workers in 2008. 57 countries fall below the World Health threshold for 2.5 healthcare workers in 1,000 in the population. So we need more qualified pharmacists, more qualified nurses, and so on. So great need. And somebody mentioned when we discussed the one or two words to describe things, yes, pharmacists are underutilized. The World Health Organization recognized that. So how can we make pharmacists more kind of utilized and so on? And they are the most accessible and sole provider of healthcare advice in many regions in the world, including in the Arab countries and so on. So very important. In the United States, the Center for Advancement of Pharmacy Education also is involved. And that's where population health and public health became more of an emphasis. And now at Creighton University, other universities, there's a course in population health and public health. And our students are gaining more and more creative, innovative ideas in terms of what they can do when they go out and practice. Culture, a lot of these things we discuss based on the accreditation and the importance of Ipes and Appes, and Dr. Gloria talked about the importance of the hours and the training that is needed. Cultural proficiency is so critical because in the United States, in Iraq, everywhere, we're dealing with a diverse population. So how can we, as a profession, how can we really optimize the care of our diverse population? People that live in Basra and Baghdad, in Mosul, and other parts of Iraq might have different health practices and cultural issues. So how can we optimize that? Our students need to be culturally proficient when they deal with the diverse population that they serve. So that became very important. Nursing, medicine, other professions have emphasized this a lot. Luckily now there is much more emphasis in pharmacy and so on. In terms of how can we do it in the classroom, active learning is important. Simulation labs, OSCEs, standardized patients, research projects, again, opportunities for dual degrees, all of those are important. What do the students do outside the classroom? So the co-curricular activities are as important, the service learning activities. Again, what is being done with Ipes and Appes? What do the preceptors do? How creative, innovative are they in terms of their training of our students? I really appreciate the fact that there is more global engagement across the world in terms of pharmacy, and students, whether in the Arab countries or the Far East Asia, Africa, Latin America, the United States, they're all interacting as pharmacy students, as educators, researchers. So that has been wonderful, and it provides for more opportunities for engagement and creativity. And I think that we need to do more and more of that. I think many of you are familiar with active learning, but these are examples. I'm not going to go through them, whether you do them inside the classroom or outside, but we need to engage our students more and more with active learning. Very important. As facilitators of learning, we need ourselves to develop new skills. We cannot continue to do business as usual as educators if we're going to be creative, innovative, and so on. We need to do experimentation, analyze, reflect, do scholarship of teaching and learning. Our teaching, our learning, the student learning need to be evidence-based. So we need to share what we do so other educators learn from it. And we need, yes, to go to educational conferences, not only basic science research conferences, to really learn how can we be better facilitators of learning. How can we be more role models to integrate our curriculum, to provide relevance. And that relevance should be both ways, both the basic science, social administrative faculty showing the relevance of what they teach, but also the clinical faculty to show the relevance of the science and the aptitude the students should have, the characteristics that they should have in being practitioners. So we, again, intra-professional sensitivity, supporting each other is so critical to graduate a student that is well-rounded, and we need to be a role model. Showing enthusiasm as educators in what we do, being role models and enthusiastic, it will rub on the students. We need to be more enthusiastic about what you do. Again, the students need to have time management skills, more engaged in their learning, more involved with leadership, advocacy, service, and so on. All of those things tie hand in hand with what we do for them to be critical thinkers and innovators and so on. Very, very important. And we want them to be more engaged outside the classroom, again, professionally and personally. Community service and all that stuff is really critical. So to kind of emphasize these points, leadership in our students is so critical. They need to be agents of change. They need to be advocates for the profession, responsible citizens locally, and we need to make them accountable for that. I have great admiration for these world leaders, Jamal Abdel Nasser, Angela Merkel has been wonderful, especially over the last few years. And with the lack of leadership, and I can say that in the United States, and we'll leave it at that. Many of you might know Jacinda Ardern, the Prime Minister of New Zealand, amazing lady, stood on the stage after sadly some incidents in New Zealand and showed what a leader, Mahatma Gandhi, was his cultural humility and the way he helped the weak and was managed to bring India in a whole new kind of era. Unbelievable. Wonderful, wonderful individual in education. Her name is Juliet Garcia. She is the president of the University of Texas at Brownsville, created so many opportunities for Hispanic students to get into higher education. And we need to do more and more of that. We need leaders that are creating new opportunities for underserved population, people that don't have a chance. So I admire her for doing that. Many of you know this, Mohammed Salah, a role model in every aspect, a leader in all aspects, not in terms of soccer. I lived in Liverpool for 3 years, so I support Liverpool, but what an amazing personality to bring in kind of a hope for people from around the world and a great role model in many ways. We need more and more of that. I admire her because she's a student, Greta Thunberg. She's from Sweden, and she started her activism at the age of 15. We need our students to be like her and advocate, in her case, for the environment and so on. Very, very important aspect. Again, innovation and entrepreneurship, very important, not to extinguish anybody, whether it's a BS pharmacist or anybody, or institutions or pharmacy schools, but to really work to be creative, innovative. The story of FedEx is a story of a student at Harvard who brought in this concept, and his business professor said it's never going to work. And now FedEx is all over the world. Many of you know Blockbuster and Netflix. Netflix took over, and Blockbuster didn't want to even buy Netflix. And now, sadly, Blockbuster is no longer, and Netflix is in existence. Again, for us, it's really about, we need to encourage that innovation, creativity in practice, in postgraduate training, and so on, to really emphasize this. Ethics, I teach a course in ethics, and that's the importance of the affective domain. Other courses, social administrative courses, are important in that respective. We need more and more our students to really work on their affective domain and the characteristics that make them good pharmacists that have value and ethics and morals and so on. So we need to build more and more on that. We also want our students to be graduates that can empower our patients. And that requires them to have good communication skills. That requires us to bring in diverse students in the classroom and create inclusive classrooms so then when they go out, they can work with a diverse population. And again, they have the cultural competency to work with the diverse population and to really optimize the care of all patients, and not only from different parts of Iraq, but patients that have physical disability, cognitive disability, male patients, female patients, elderly patients, young, all of those are different cultures that we need to deal with. People that cannot speak, they have autism and so on. So mental issues. How do we are culturally competent to deal with the diverse patient population that we deal with? I'm not going to discuss too much. We're getting close to the end of the lecture, but everybody knows in terms of the innovation that the PharmD degree have created and so on. And now we're getting more and more with our PharmD graduates and again, BS graduates that have done great job with clinical pharmacy, established collaborative agreements, getting a provider status in some countries. The United States, we're trying to do that. And prescriptive authority, Canada have that. I know in the Arab world, in a certain extent, pharmacists can, it's changing, there's regulations, but people depend on pharmacists in the Arab world in many ways and so on, but we need to get to the level where it is regulated and the pharmacists have the right training and so on to do this. We need to expand the job opportunities based on these disruptions and so on, using informatics, again, being coaches for wellness, immunization, smoking cessation, healthy lifestyle, chronic disease management. All of these things we need to, and in the industry, what are the opportunities there? Specialty compounding is very big in the United States, and there's pharmacists that are dealing with specific diseases now and helping patients with those diseases, whether it's immune diseases or pulmonary hypertension and so on. Very, very important. I'm going to skip through all of this. You can go through that, but it goes through the whole history of what happened in the United States, from pharmacists going from the inpatient pharmacy up to the floor and working as part of that team, being in the infectious disease, antimicrobial stewardship, pharmacoeconomics, TPN teams, you name it, and then anticoagulant clinics, all aspects being on the transplant team. So it shows some great innovation that happened in pharmacy practice. And I'm sure you could do your own thing in Iraq. Some of the people that felt maybe it's not as progressive and so on, I think somebody needs to really establish a figure like that for Iraq and what happened. And God willing, you'll see that there is a lot of creativity and innovation in what's happening and so on. So again, I'm going to skip through that. A lot of the stuff we already talked about in terms of innovation. Clinical research is so important in the United States. Everywhere, pharmacists need to be involved, providing new guidelines for treatment, a new creative, innovative treatment and so on. Very, very, very important aspect of being creative and innovation. Again, we talked about this. Pharmacogenomics is critical. Cancer treatment is becoming more and more involving the genetics of the patient to see the optimal dosing and so on of these drugs, minimizing toxicity. Pharmacists can play a major role. They can play a major role, again, in P&T committee and ADR monitoring, major aspect and so on. These are future opportunities for pharmacists. A lot of those, we talked about that. Again, the provider status, prescriptive authority, partnership with insurance companies. Telepharmacy was mentioned yesterday. COVID have really pushed medicine pharmacy to be creative and utilize telemedicine and telepharmacy. And our students are, as was mentioned earlier with Dr. Joseph, will be involved in a lot of that for their rotations, their experiential experience. We have to be creative, innovative in how we do this. And as you saw, he's trying to document this and present it and write papers about it. So we need to do more and more of that. I think value-added reimbursement is really critical because everything now is being scrutinized, and the more we show value in what we do, the more potentially we get reimbursed for our activities and what we do. These are future goals, hopefully, for us as pharmacists, as experts in patient safety, wellness coaches, experts in pharmacogenomics, managers of chronic diseases. It's happening now again in many countries. Practice models in community pharmacy. If we have time, I would have shown many examples of that, but many creative, innovative ideas. And again, the residency training is so critical. How do we refer patients among ourselves as pharmacists and help with reconciliation of drugs as pharmacists move, as patients move from the hospital setting to the community, or from the community to a nursing home? Pharmacists can play a major role with that. Pharmacovigilance, everybody understand the importance that medication error prevention is major, and there might be many other ways, especially regional issues that you guys need to deal with, and hopefully find ways for pharmacists to be involved. These are the challenges. We discussed a lot of those: the quality of students, practice, educators, the sites in rural areas. Do we pay the sites for the training and so on? How do we demonstrate the value, the job opportunities, workforce projections, especially under COVID and other disruptors that are happening and so on? And what is the competencies we want the pharmacists to have when they graduate? And meeting, again, the needs of the healthcare system is a key thing that we always need to keep in mind. I know this was kind of fast and furious, but getting back to really the last objective, which is what is needed and what are the current and future opportunities for disruptive innovation in pharmacy in Al-Mustansiriya University College of Pharmacy in Iraq. I hope that kind of this have challenged you to really think about it. What is it that this is Risalatul Kulliyah for Al-Mustansiriya, and I hope you all read it. And for any other pharmacy educator, what is your message, your mission for your school? And to really try to look at this and see what do you need at the education level, the training level, that what do you want the pharmacy graduates from your school to look like? What are the pharmacists that are practicing and they graduated from your school, what you want them to look like and how they practice? How are you creating job opportunities? How you're working with the Ministry of Health, with the Ministry of Education, Labor, and so on? What are other things specific for you? Again, the presentation hopefully have created some ways for you to think about this. These are questions to ask for you and anybody really in any profession, including pharmacy. What is the vision for pharmacy educators? What is the practice that you want in your kind of region, in your locality where you're working? The mission, the reason and motive for what we're doing, the strategic objectives, what are the strategies that we're trying to implement in the education and pharmacy practice to achieve those? What are the action plans that we put in place to achieve them? And what should the graduates look like? What is their role in society? How do they meet the need of society is so critical. And again, the job opportunities are so critical. We cannot graduate more and more pharmacists and there is no job opportunities and they become disillusioned and so on. That happens here in the United States. That happens everywhere. So if we open new pharmacy schools, the whole issue of disruption and innovation has to be in our mind with goals to create more job opportunities, research opportunities, creativity, and so on. Very important. And how do we work with all the stakeholders to make this happen? So in summary, real quick, 3 major points. Again, Dr. Joseph shared about disruption, but that disruption due to COVID was external to pharmacy. When we think about disruption and innovation as pharmacy educators and practitioners, we need to be in control. We need to be visionaries. We need to be creative, innovative, so that we create opportunities for disruptive innovation while we are in control and foreseeing, God forbid, pandemic like COVID again or other things. But because we're creative, innovative, we know how to deal with it. And distance education have helped tremendously and other practical ways. Dr. Mohammed Rahal will also talk to you about some of the amazing things that they've done at the Lebanese International University, I hope. Again, academia practice as well as individual pharmacy educators can play a major role, and advocacy, leadership, and networking are key for success. I want to thank you. I want to thank your dean. I want to thank Dr. Ali, who started this kind of collaboration from the University of Baghdad. I want to thank you all, the virtual audience, for being with me. Shukran لكم, يعطيكم العافية, and I'm happy to answer any questions.
Thank you very much, Dr. Asharif. Shukran jazilan. Thank you for this informative lecture. And you are right, the best thing to deal with the pandemic is to think outside the box. So I'll leave you now with Dr. Mohammed to run the Q&A session.
Thank you.
Thank you, Dr. Atmar, and thank you again, Dr. Nasser. I would like to remark on 2 points. First of all, you mentioned the barriers to innovation in pharmacy profession. Some of these barriers like outdated curriculum, or as you said, stagnant curriculum, and maybe lack of a mutual relationship between academic output and the practice in healthcare system, and also the lack of appreciation for clinical pharmacist role. Unfortunately, all of these was exactly happened in our healthcare system. We hope to be more active in the future. Second point, in our country and some countries in the Middle East, many of the innovation requirements you mentioned in the presentation, I think it's weak or maybe absence. And also this needs hard work to be active and applicable. And this is a big responsibilities. We can start with the question. Let me start with my own question about the clinical training, the field work in case of distance learning. As you know, students cannot physically present in the hospital wards, and there is no direct contact with the patient, with the case. So what are the proper way to get the full benefits, full practical benefits from this type of learning in situation like COVID-19?
Yes, thank you for the question. Again, being creative, innovative means to think out of the box. Many institutions now are trying to deal with COVID, including my institution. So over the last 3 months in the summer, we have established guidelines for faculty going back to school, for students going back to school, for staff going back to schools, and for our students going back to clinical settings in collaboration with the sites, with the preceptors. So the key thing is to be proactive and so on. Our accrediting body certainly have somewhat been flexible, recognizing what is happening with COVID. So you need to work closely with your accrediting body to make sure that whatever you end up doing in the experiential experience is acceptable by your accrediting body. And that's what all the schools in the United States have done as we had to deal with COVID. Our preceptors, especially those that are internal to our school and hired by the school, have been instrumental in terms of putting the guidelines for how our students are going to go back and practice safety and so on. We as educators, we have to wear masks, where the students have to have distance. We have to be creative in terms of the classrooms and getting the largest classroom to accommodate students and have them sit at a distance. So yes, it can be done. Now, you don't want to compromise safety of anybody. So if it is not possible, what else can be done? What can be done in simulation? What can be done using the technology? We have done a lot of our interprofessional education using Zoom. I was involved with cases with nurse practitioners, physical therapists, OT, and our pharmacy students, where they had to all be in a room on Zoom and addressing a case with a patient, all from their perspective. and then getting together and finding a solution for that patient. We were able to do that for all our students with these cases that we used to do on campus. We did it using Zoom for both our campus and distance students. So we just need to be creative, innovative, be proactive about it to ultimately provide the best experience, whether face-to-face with the proper precautions and so on and guidelines, or again, what can technology help us with? Our skills lab have done fantastic with both our campus and distance students with compounding skills and other skills, patient kind of specific skills and so on. And everything was done online. And again, we've been fortunate because our distance pathway has been in existence since 2000. So we've been able to really address a lot of these logistical issues based on going distance. I hope that kind of addressed the question.
Yes, that's right. Another question, how could we make a balance in the curriculum to provide the required competencies of pharmacists with multiple career options, including industry, for example?
Excellent question. And I think that goes to this intra-professional sensitivity. And it goes with that in terms of across countries. Clinical pharmacy certainly is critical, important, and has provided the pharmacy profession in many job opportunities, absolutely. But many countries, even here in the United States, in the eastern part of the United States, a lot of the universities still cater for the industrial kind of pharmaceutical industry and so on. So they have courses in industrial pharmacy and so on. Very critical. You need to know what are the needs of your country. Some countries in the Arab world have a pharmaceutical industry. The students need to be trained because they need to fill that job opportunity, whether it's in Jordan, whether it's in Saudi Arabia or other countries that have Oman, for example. I've been there. They have a good, excellent pharmaceutical industry and so on. So absolutely, there has to be a balance, and it all should be based on the needs of the healthcare system, the needs of the students in terms of job opportunities and so on. So that balance has to be existing, and the students have to have in the curriculum those kind of opportunities.
Okay, another question from Dr. Ali Aziz. Do you have an example of way to increase the innovation of our students? In brief, please.
Well, I mean, our students are involved in all kind of activities. For example, when we talk about global engagement, we go out to the Dominican Republic and we basically establish clinics in 6 different communities. And for us as healthcare providers, we are there, especially for pharmacy, we're there for the first week, the second week, to help them establish the clinic. And then we leave and they run the clinic, and we have every confidence in them running the clinic. I've done kind of similar things when I travel to the Arab world, talking to faculty members, how students can help with these kind of service activity and giving them the opportunities to be the ones in charge of it. And they've done some things in Oman, some things in Jordan, where they became really involved with patient education and taking on the responsibility with the support of faculty, but ultimately they own it. They're the ones that are in charge of that program. We send our students to do immunization all over across Omaha, Nebraska. Our whole faculty and staff are immunized at Creighton by our pharmacy students. And again, we supervise, but a lot of times everything, the education of all the students, staff, faculty, and so on is done by our students. So you need to create opportunities where they are in charge, where they're being accountable, and not only in the practice setting, but also in the classroom. How do you make them accountable for their learning, whether it's group activities? I teach a course in clinical toxicology. I require them to go to an emergency room if they live within 30 minutes of a poison control center. And they are supposed to really be in there to provide, based on what they've learned in the class, some ways to change potentially what is being done, or to show how they impacted even in 2 days. Our students go for 5 weeks rotations, and we always want to document how creative, innovative they are in terms of impacting the site where they are practicing. So again, making our students accountable regardless of what the requirement is, whether it's in a classroom, whether it's a service activity, whether it's the IPEs, the APEs, and so on. It is that kind of sense. Now you have to be identifying yourself as a potential pharmacy practice or practitioner, and you need to show me what you're capable of doing so, and how creative, innovative can you be. Again, hopefully that gives you some perspective.
That's right. Okay, so I think we don't have time for more questions. Thank you very much, Dr. Nasser, and thank you to be being with us, and see you soon. Thank you.
Well, thank you very much. I appreciate it, and all the best for the rest of the conference. And I look forward to hearing Dr. Rahal speak now. Thank you.
Now, I will go back to my colleague, Dr. Athmar. Mike is yours.
Thank you very much. Thank you very much, Dr. Mohammed. Thank you very much, Dr. Ashari. Our third speaker of the day is Professor Mohammed Rahal. Dr. Rahal graduated from the American University of Beirut in 1991 with a bachelor degree in biology, followed by a master in 1992 and a PhD degree in pharmaceutical chemistry in 1997, both from Bradford University, United Kingdom. He started as an assistant professor at the Lebanese American University in 1998, and he was involved in the establishment of the School of Pharmacy at the Lebanese International University in year 2002. Currently, Dr. Rahal is the Dean of the school and a professor in pharmaceutical chemistry. Also, he's a member in a number of regional and international organizations in pharmacy education. To name few, he's a member in Hpac Advisory Committee and ACPE International Service Program Advisory Group. He also participated in several national, international conferences and faculty development workshops. Welcome, Dr. Rahal, and thank you for joining us today. The screen is yours and you can share your slides.
Thank you everyone. First of all, I would like to say hi, assalamu alaikum to everyone, and to thank the organizers of this conference. Thank Dr. Inam and Dr. Munder for giving me the opportunity to participate in this virtual conference. I am very honored and very glad to be with you. First of all, my topic is to share with you our experience during the pandemic. The title of the presentation is Transforming Challenges into Opportunities. We know that all of us, we faced many challenges during the pandemic, COVID-19 pandemic, and we tried to cope with them. We tried to make the best of them. We tried to improve and take opportunities from these challenges and the pandemic. So my presentation, I hope you are not tired after this two valuable presentation by Dr. Joseph and Dr. Nasser, and this time of the day, but I hope you can be somehow interactive and you are still energetic, and you will find my presentation interesting and somehow informative. My presentation outline will talk a little bit about my school, the establishment and the degree and our mission. And then I will mention or list the challenges that we faced during the COVID-19 pandemic as a university, as a school, as a country. And then I will talk about the pedagogic changes and the adoption of some teaching and learning techniques and tools during the spring semester, and then continued with the summer semester. And we did many studies during this pandemic to take feedback from students, faculty, not only our students, our school, but we also surveyed students from different schools of pharmacy in Lebanon, and we took their feedback, their perception and satisfaction with the online teaching. And then I'll talk about the opportunities, and for the new academic year, what are our plans, what are we going to do for the next year. First of all, I'll start with the background about my university. It was established it's younger than your university. I know your university was established, or the school, in year 2000. Our school and university was established in year 2002. And the same year, the School of Pharmacy was established. We started with a Bachelor of Pharmacy program that is 5 years program, but it is somehow similar to the American system. We divided the curriculum, or the 5 years, into 2 pre-professional years. These 2 years, some of the courses are taught by instructors or faculty members not from other schools like School of Arts and Sciences. And then these are about 165 credits. And after the completion of the 2 pre-professional years, students can be promoted to the professional years based on their achievements, their academic achievements, mainly based on their GPA or major average. The professional years is a 3-year program. It is our program, our curriculum is clinical oriented. We have, it is not traditional pharmacy program that is based on pharmaceutical sciences. Rather than, I will show you the philosophy of our program, but it is a clinical oriented, patient-centered curriculum. Then in year 2010, we started our PharmD program. This was a post BS or BPharm degree after graduation. It is 1-year program that is mainly clinical rotations in the hospitals with 1 or clinical advanced pharmacokinetic course and statistics or biostatistics course, because the PharmD program has a thesis, and the students have to write a thesis and submit it for publication, and they have to do articles. We have 2 campuses for the pharmacy, although the pre-pharmacy or the pre-professional years are taught in 8 different campuses in Lebanon, but the professional years are only offered in 2 campuses, 1 in Beirut and 1 in Bekaa Valley. What is our mission? Of course, the one that is stated by Dr. Nasser, or that vision, it was not ours. I knew it. Our mission is to develop pharmacists or distinguished professionals in pharmacy practice. Pharmacy practice in all of its domains, and professional pharmacists in research, in community services. We also feel that our graduates, our pharmacists, should have good link, good outreach to the community and to serve the community. And this is established, or this is achieved through a dynamic educational program that is aligned with national and international standards. So we always keep on improving, reviewing our curriculum, and add some courses that are based on the needs of the society, based on the needs of the profession. Some of the courses that we added to our curriculum, for example, in the last years, are cosmetology. We know that most pharmacists, they are asked about cosmetics more than they are asked about drugs. So we added a course about cosmetology. We added pharmacogenomics that was added early in the curriculum, and other courses such as career development, because we know that our graduates, they don't pathways. This is the philosophy of our curriculum, or our mission and core values. So our foundations are quality education with its intensive experiential learning. We integrate in our 5-year programs about 1 year, or about 1,440 hours of training in community pharmacy and in clinical settings. So we have a very intensive experiential education program that is integrated in the bachelor curriculum. We also, our foundation research skills, we want our graduates to be, this is integrated and developed throughout the curriculum. And community services as extracurricular activities. Our students are also competent in community services. Our core values are collaboration with practice sites, with institutions, our diversity in the curriculum and the staff, our dedication to our profession, to our students, clinical-based curriculum, integrity and the trust. We respect our students, we respect our colleagues, we respect our also partners in the profession and our other healthcare professions. Also, we believe in leadership in our students. These core values and foundations to achieve our mission in professional pharmacists. The curriculum, our curriculum philosophy and design is explained in this graph. In year one, we have mainly basic sciences in biology and chemistry, biochemistry, anatomy and physiology. And in year two, less basic sciences, more biomedical sciences, pathology, and medical biochemistry, some pharmaceutical sciences courses. These are in the pre-professional years. Then in the third year, we have less biomedical sciences and more pharmaceutical science courses like dosage, physical pharmacy, medchem, and so on, and some clinical skills and PPE pharmacy practice experience in the summer of the third year. In the fourth year, less biomedical and pharmaceutical sciences, but more clinical sciences as therapeutics. Our curriculum has 18 credits of therapeutics, and also in year four, we have some pharmacy practice education in the summer. Fifth year, it is half clinical skills and pharmacy practice. The pharmacy practice in the fifth year is based on clinical rotations in the hospitals, and the sixth year or the PharmD year is mainly pharmacy practice, clinical rotations, advanced clinical rotations in the hospitals and the clinical settings. During the academic year 2019-2020, we have many, as I said, the challenges. First of all, challenges at the country level. Lebanon was under unstable social, economical, political situations. We started the academic year in October, and then immediately the strikes and the protests started in October 17. We had many days closure of the university, sometimes in more campuses other than campuses. We had at this time we had to try different or alternative methods of traditional teaching. And from here, we started, some of our instructors started with remote or virtual online learning. At LIU level, the challenges, or we had two major projects in this year. One of them is the institutional international accreditation. The university was applying for international accreditation, European accreditation, EVALAG, and HCERES, French and German accrediting bodies. And the School of Pharmacy in the same time was at the middle of its certification application to ACPE International Services. We applied our self-study report in September, and we were doing all the preparation. The visit was scheduled for the online evaluation team was scheduled in March 10th to 13th March. And at that time, the spread of COVID-19 was increasing, and we had, during that visit, it was a big challenge for us, thanks to the evaluation team. One of them was Dr. Nasser Z. They made very great job during that visit. We had to condense to the visit or the meetings of during the visit. And this was our biggest challenge during COVID. Other challenges that regarding the academic year are listed in this slide: teaching and learning. I know I participated in a Zoom meeting with our colleagues and deans from Arab universities, from Damascus University, from Munstansiriya, from Libya, from Egypt, from Oman, and we all had the same challenge: teaching and learning. We had a big resistance by our students to online and virtual learning. So it was not easy to move from traditional teaching, from classroom teaching, from lecturing in the classroom to lecturing virtually and online. So I had to meet with the students of every year, fourth year and third year and fifth year. I had to convince them that we are working for their best and we cannot stop or delay the initiation of our education. And later on, we will show you some of the perception and satisfaction of students after we surveyed them. Assessment was another big challenge and still is a big challenge. The assessment of online teaching, it is never going to be never identical or as same as on campus or in class assessment. There are many challenges, many difficulties of performing transparent and realistic assessments, but we had to implement some assessment tools that allow students to put more effort and to do more job other than the traditional assessment or quizzes and exams that are done in classes. It was a challenge as a new experience for faculty and the students. We had not only students who are resistant to online, faculty members, but they are what we call digital ignorant. They have limited. Most of them they used, or not most of them, some of them they used to use the board rather than using digital or learning or PowerPoint presentations, and they had to transfer all of their teaching materials from their mind or from their notebook into digital or into material. We had the socioeconomic and psychological challenges. Our students come from different regions of Lebanon, so they don't have, in some regions they don't have good internet. Some of them they had to share their devices with their brothers, with their family members. Some of our faculty members, they have double challenges, and because they wanted to be as instructors, as teacher for pharmacy for their in their institution, and in the same time to follow up with their kids' online learnings. And this was a big challenge. Some of our students, they are working and they lost their jobs, and they had also this financial challenge. Internet connection, it is not stable. It is very expensive in Lebanon. So this was another challenge. Stress and workload, and this is a big challenge for students and faculty. It is not as simple as the traditional educational methods. The stress and workload on our students and faculty. We received many complaints from our students about materials they were receiving. They don't have time, and we try to also modify our approaches. With respect to our experience, I hope you most, if you have any questions, if you have any thing you want to ask, you can ask it now or at the end of the presentation, but you can at any time stop me and ask for further information. We had 3 types of courses as any school of pharmacy. We have the didactic courses, we have the laboratory courses or experimental courses, and we have the experiential and simulation courses. With respect to the didactic courses, it was mainly the easiest because we have the handouts that we used mainly Google Classroom as a platform for our education, for our teaching and learning system. Google Classroom is embedded in the Google suite, and we used to have asynchronous delivery or teaching. We send our material as PDF files to our students. Sometimes we also explain lectures as voice over PowerPoints, and we send it to students before, at least 2 days before we go online or we go to synchronous delivery or teaching. So after we send the recorded lectures, we went live with the students via either Google Meet or Zoom, but our main tool was, or the platform was, the Google Meet. It was very easy to invite students or to and record even the live session. It is interactive, and it is free and doesn't have like Zoom limited duration. So usually we want live once or twice per week as scheduled, as the same time as the course was scheduled in class. Sometimes we go over the lecture. We review the lecture with the students, and then we give time for questions and answers and the class discussion and clarification. And we have different tools or different activities like presentations and the projects. When we surveyed or asked the students about their satisfaction with the teaching tool, 29% of the students, they preferred the voice over PowerPoint as a teaching method. However, 21% they preferred the live sessions or meetings, but the majority, 45%, they prefer to do both, send the voice over PowerPoint and then go live and discuss or review the lecture and discuss the main topics and also have the question and answer sessions. Also, about 96% of the students, they were satisfied with the student-based formative tools that were used during the online teaching, such by assignments, reports, and homeworks. And Dr. Ali was asking about the creativity of students. It is when you assign students, when you give them something that is non-traditional, you will see creativity. The assignments, reports, and homeworks, some students used to copy paste from internet, but some students were very creative, very good in writing and presenting their assignments and their reports. And this is the opportunity that you gain from challenges. This is a new challenge, a new experience for our students. And then we gave them the opportunity to be creative and to express themselves. Regarding when we asked the student about their satisfaction with the Google Classroom, 60% were agreed or strongly agreed that it is a good tool for online teaching. However, 14% only of the students disagree. And this survey was answered by about 450 students from our school. About 73% of the students found that it is useful tool for Google Classroom for accessing and reviewing study material, because the material is there. They can download, they can access the lectures, the video anytime. We used to face during live sessions bad connections with some students. but because the sessions are recorded and the lectures were recorded previously, so they could download and watch these lectures at their free time or other time during the day when the connection or when the internet connection is good. When we also surveyed the students about their perceptions of online learning, and online learning activities can be applied in all pharmacy courses, of course, 50% of the students disagree or strongly disagree that online learning can be applied, can be used in all courses. We know that. We know that some courses, some pharmacy courses, they can be taught only by practice, laboratories. As pharmacists used to be chemists, mixing, preparing drugs or solutions for dosage forms cannot be taught virtually. It needs skills. These skills cannot be obtained, cannot be practiced, cannot be gained by virtual learning. We know that. And only 23% of students, they agreed that it can be used in all subjects. However, 53% of the students, they found that traditional teaching is better than online teaching is better than traditional or online teaching is better than the traditional tools of classroom. So 53% disagree about this. So the majority, they disagree about online teaching is better than traditional teaching. Not 53 agreed, no. The 53%, the majority, disagreed with this term, if online learning is better than traditional tools. Students' attitudes about online learning, when we asked the students about the usefulness of online learning, 57% of the students agreed that it is a useful mean of learning. So it is not perfect, it is not a replacement of the traditional tools, but it is, in these conditions, it is a useful tool for online teaching and learning. 67% of the students found that online learning is self-motivating, or they were self-motivated by online learning. And we know that this is a big challenge faced by us when we want the students to be motivated to search, to look for information, to study more, to think outside the box. It is very difficult, so that when we use these tools, so 60% of the students found that it is motivating, or it is self-motivating, the online learning. At least they developed and they advanced digital skills, their digital and computer skills. Our second challenge with teaching and learning was the laboratory courses. We know, we experienced this, we all did experiments, and this was the best experience, the best part of our education, the laboratory works. When we prepare chemicals, when we do reactions, when we separate things, this was the best thing, or the best experience of our education. So how did we perform the laboratory courses? COVID-19 started immediately, or when we started the semester. So at the beginning of the semester, most of the students did not do any, the second semester, the spring semester, any practical course, labs or experiments in the university. So we did similar to didactic courses, asynchronous delivery. We, using Google Classroom, explained lectures over PowerPoint, and we downloaded from the YouTube some experiments that are related to the courses, some experiments on dosage forms, some experiment in pharmaceutical analysis, some experiment in quantitative analysis. So we downloaded some experiment about analysis of aspirin, analysis of drugs, using spectrophotometry, using chromatography, using polarimeter. They are not the same experiments that we do in our courses, but they are similar, at least the techniques similar to our experiments. And here, the opportunity we gained from this challenge, that was not part of our dosage or our laboratory courses, we added to our laboratory courses preparations of sterilizers. Sterilizers of different forms of sterilizers. We asked the lab technicians and lab instructors to search for students to how to prepare different forms of sanitizers, the gels, solutions, liquids of different sanitizers and different dosage forms. Also, instructors prepared some videotaped demos at home, but this was not the major tool. After these tools or delivery systems, then same as didactic, the instructor went live via Google and Zoom meeting to discuss the experiment with the students once per week as the same time of the lab, because the lab is usually once per week. Students were asked to write reports about the results of the recorded experiment and to present the reports. And we will now show you the results of the survey or the study that was conducted with students about their experience and perception of laboratory courses. When we asked the students about the simulation videos, the videos that we downloaded from the YouTube, 60% of the students said it is easy to access, it is easy to watch it, and as many times as they want. The length of the video was 60% of the students found it is suitable. The length of the video, it's not too long, it is not too short, and it is 67%. They said the video, the simulated video, that the YouTube video were with good quality. When we ask the students about skills here, of course, we expect this. When we ask the students about the skills developed by the simulated experiments or the videotaped experiments, when we ask them about the learned practical skills, of course, only 17% of the students agreed that they learned the practical skills. But we expect that more than that, about 80% of the students do not agree with them. When we ask them about if they learned fine motor skills, of course, only 20% said yes, and the rest said no. About if they learned the details or how the machines work, how the devices, the spectrophotometer work, and of course, the majority did not agree with us that they did not learn the how do the machines, HPLC, LGC, and the spectrophotometer work, because they did not do the real practice. Sorry. When we asked the students about the learning outcomes of the lab course, 50% of the students, they said, yes, the goals of the course was met. So 50% agreed that they met the goals of the experiments or the courses. Only 47% were able to analyze and interpret the results that were provided to the students from the videotape, and 50% were able to write structured and organized reports according to instructors' evaluation. So writing the report from the virtual experiment was not, only 50% of the students were able to do it. The third kind of teaching and learning was experiential and simulation courses. I know this was asked by Dr. Nasser about how do you perform clinical rotations virtually, and this was a big challenge. Our students in the 5th year, in the last semester, they have to spend 4 months in the clinical rotations. This was the biggest challenge to us, clinical rotations. The first, because we do not control it. We are affiliated with many university hospitals in Lebanon, very high quality universities that have School of Medicine, nursing, and they have different healthcare professions. And our students in the 5th year, after they finish all their didactic courses, almost they are ready to graduate, they go and do clinical rotations for 4 months, usually in 4 different specialties, and 1 in the hospital pharmacy. So it was not up to us what is the alternative or what shall we do, because most universities, they did not accept students in not only pharmacy, but pharmacy and medicine, nurses to do their clerkships or experiential education during the COVID-19. And of course, parents were also sending their kids to the hospitals. And so we want our students to achieve the outcomes, the learning outcomes of these courses, and we try to do the best. First of all, we collected real patient cases. These real patient cases were either collected from previous years or from our adjunct preceptors. Our adjunct preceptors, that they are pharmacists or clinical pharmacists in the hospital. So they send us their cases, and then they are discussed with the instructor, with the faculty preceptor, same method using Google, Zoom. We used to have virtual patient monitoring. The preceptor, the university preceptor, the school preceptor was acting as a patient. They used patient screening, intervention scenarios, and like simulation scenarios for patients to simulate the patient case, and the student has to ask the patient or the instructor as if the patient. Also, they did topic presentation and journal clubs virtually, they prepare topics and about medications, about diseases, and they presented to their colleagues. Also, we did virtual dispensing community cases. In some time, they have to talk about not clinical, not a patient, but about a medication in community settings. Also, they did some activities like guideline updates, drug review, article discussion, and medical talks. These are the virtual rotations that were done. These were followed by synchronous delivery, weekly live meetings, as group discussions, as one-to-one discussion, as discussing assigned cases and activities, presentations, and so on. When we asked the students about their perception, and this was asked to students from all universities, not only from our school, to rate from 1, which is the least, to 5, which is the most, about the convenience of virtual rotation. 12% of the students, they said it is convenient. They give it 5 over 5. 25%, they said it is convenient as well. But we can see that the rest, which is about 75 or 65%, they did not find it convenient or replacement of the rotations. But when we asked the students if they prefer to go at least 2 to 3 weeks to hospital, 89% of the students, they said yes, they want to go to do at least 2 or 3 weeks of clinical training in the hospitals and not virtually. But unfortunately, we were not able to do it because it was not up to us, it was up to the sites, to the hospitals to accept them or not. When we asked them about the benefits of virtual rotations, and we expected that only 4% of the students, they give it 5 over 10, and 40% of the students, they gave it 4 over 5, sorry. So only 5 strongly agreed, and 40% agreed that it was beneficial, the virtual rotations. And the rest, they found it, and only 17%, they found it not very well beneficial, the virtual rotations. What about the assessment? Of course, teaching, interaction, delivering information was not easy, but can be done or with little problems. But what about assessment? And this was the biggest challenges, not only in our university, not only in our region, in the Arab universities, but also internationally. I participated in webinars with discussion with international colleagues from Europe, from United States, from Asia, and this was the biggest challenge for all of them during the online teaching assessment. How to perform reliable, transparent, reflective assessment. So in didactic courses, we did online quizzes and exams using the Moodle and Google Forms. We used to give versions of specific duration, monitor students' access to the quiz and duration they usually took to finish their quizzes. And sometimes we give them projects, group projects. In my course, I give the students some projects in medicinal chemistry, and they did a presentation, and that was kind of active learning where students were assigned certain topics in medicinal chemistry. They have to do it. They took 1 month to prepare the topic and present it. Assignments, regular assignments about certain topics also were given. Sometimes open book exams and article appraisals and presentation. And of course, some of the grade was on participation. Laboratory courses, reports, assignments, also online quizzes, and were used as tools. Also, we did videotape experiments. We gave the students, we sent to the students recorded experiments, and we asked them about that experiment to mimic the practical exam that we do in the lab. The experiential education, also we did online quizzes, projects, assignments, and preceptor evaluation and self-assessment tool for assessment. When we ask the students about their satisfaction about the assessment tools, so 59% of the students, they found it was efficient. The grading system and was clear. 60% of the students found it clear. They strongly agree and agreed that it was clear, the grading of the assessment. And 49% of the students, they preferred on-campus assessment and quizzes. When we asked them about if the Google Classroom is useful, 70% they said yes, the Google Classroom is useful for assessment. 50% they preferred Moodle, and 43% of the students said they would have got the same grade if they did assessments in class and on campus. What about the other challenges? As I said before, other than teaching and learning and assessment, we had the challenges with experience. Only 67% of our faculty, they didn't have any experience with online virtual teaching. We had also, as we struggled with the students to accept that the new tools, we also had to convince and train, and we had to do many meetings, virtual meetings, and this added the workload on our administrative staff, our chairs, our assistant deans, our course coordinators to communicate with the instructors and to train them and to guide them about the use of online learning. I think you had the same experience. The workload, when we asked our staff about the workload, 72% of the staff said the workload of online teaching was higher than and much higher than the traditional teaching. The socioeconomic challenges such as the low income devices, sharing devices, low internet, no connection and availability was challenges, and the stress on the faculty and the students due to the socioeconomical conditions and of course the health conditions in the country were also challenges that we have to always meet with the students. And they used to complain about teaching. They used to complain about some instructors. They used to complain about some methods of teaching. They used to complain about assessment, how are going to assess us. We used to always meet with the students online with Google, and we were calming them. We were assuring them that it is for their benefit. We don't want them to be delayed. This is international trend. It's not only localized or for our institution, and we had to always deal with these challenges. What about next year? What about the opportunities that we are going to gain from these challenges? First of all, with respect to teaching, are we going to do online teaching for the next year? Until 2 weeks ago, we were thinking about online or hybrid teaching or blended teaching. Some teaching in the class in the school and some teaching online. Of course, in the last 2 weeks, we had a big rise in the number of COVID infected patients. And now we had the new challenges. So we are now thinking of online teaching. If we want to do online teaching, we have to implement changes. We have to implement improvement to our system. Are we going to do labs on campus? This is still debatable if we are going to do it, but at least during this period, we are preparing our experiments. We are recording, and we are happy if you would like to share with you our recorded experiments in our labs. We recorded all experiments of our courses in our labs, and we will share them with our students. Experiential education also, we want it to be done partially on site because the students, they want it to be on site. So they want some on-site practical experience, but it is also not up to us. We have to communicate with the hospitals, with the sites, and we already did. And many sites they agreed to accept our students in the coming year, and we were thinking about 20 to 50% of in-class on-campus teaching and the rest online. What about our student services? Everything now is online. We used to have many paperwork, signing petitions, signing requests, now everything is done remotely and online and digital. Online recruitment, we know all of us now, we are accepting new students. Students are applying online. Exams, entrance exams, some of them are done online, some of them are done on campus. We have to orient our new students. We used to give orientation for new students on campus because they are moving from the schools to university. So we were talking about some rules and regulations about the university and mainly about the pharmacy, also education and the program and university life. What about our extra and co-curricular activities? We have a good investment in our students. Our students participate in many extracurricular activities, and this is the opportunity for them to be creative. We had many activities like celebrating with the World WHO Health Days, Diabetes Day, Kidney Day, Hypertension Day, and so other. We had to do like awareness campaigns in the community, like in the shopping centers, and sometimes we go to the orphans, to the schools, to the high schools, and we give students some health awareness tips about the drugs, about antibiotics, and so on. How are we going to do this? We are planning to do all of these activities online and virtually, and to be posted on our social media. Also, students' committees and representation in the committees. This will be done online. We will include our students in the school committee, and they will attend our online meetings and we will have selection or election of students online. What about for our faculty and staff? Of course, online teaching is not only PowerPoint. We are going to do training sessions for online to use different techniques, to be more interactive, to be more creative, to be more suitable for the students with respect to their, especially the new students. The new students, I think this is not only in Lebanon, everywhere. We know that the secondary school students, they did not finish their curriculum, and we need them to be transferred gradually from the school or from their high school courses or subjects to the university or to college level. Research activities and resources, research activities will be redirected to different tracks. We will more do research about digital learning, online learning, about teaching and learning outcomes, rather than do research in the labs, traditional or basic science research. Workshop and on assessment, this will be done Sorry, I lost the connection, and I know that it took a long time. So these are the opportunities and the planning for the next academic year. Our community outreach will be remodified to do more social, to reach or to outreach the society and the community through our social media, through our website, online magazine, our collaboration with the institution, with the hospitals, with some organizations that are now active in dealing with the COVID-19 pandemic. Also, I will do online collaboration with these institutions and organizations. Labs, we are preparing as I said, we are recording our experiments. There is a software called Labster that has virtual experiments. We are going to also maybe to implement it. And we are thinking of doing some experiments on campus if we are allowed to, not only due to the COVID-19, but you will know due to what in a minute. This is for experiential education. How I'm doing with time? Do I have, how long do I have? How much? Dr. Athmar?
5 to 10 minutes, I think.
5 to 10 minutes.
Yes, less than 5 minutes, okay.
5 to 10 minutes.
Okay, with improving experiential education and simulation, now we are collecting cases from our hospitals, our affiliated hospitals, from our adjunct preceptors. We are going to do workshops for our preceptors, faculty preceptors, and adjunct preceptors about online, about how to mimic or to simulate the real rotations into virtual rotations. We have to renew our agreements with the practice sites. We started now renewing them. As I said, not all practice sites are allowing students to practice. We are going to also recruit our students during their experiential education in some of the COVID-19 units or voluntary activities that are organized by the Ministry of Health and by the Order of Pharmacists. Also, we are going to do hybrid rotations online and on-site. We have to do few hours at least. I was discussing it with our experiential education department. We have to do at least 2 hours, 3 times a week in the hospitals. I say it always, where there is a will, there is a way. We have challenges. We have to face these challenges. We have to take the best and make the best and take a new approach in during these challenges. But are these challenges finished? Challenges to us continue. You are all aware of the recent event in Lebanon, the tragic event, explosion that happened in Lebanon that affected the whole population, not only in Beirut, but everywhere was affected. This is our offices. Then Beirut in the school. This is the one to the left is my office, and then this is the second one is the assistant dean office in Beirut campus. These are our labs. Glass were almost all broken. This is the dissolution tester in the pharmaceutics lab. It fails and it was all broken. This is the entrance of the building. These are the classrooms and the offices of our faculty. And by this, I come to the end. I am ready for any questions. These are my contact if you want to contact me for further details for any information. And thank you.
Thank you very much, Dr. Rahal, for this great lecture. Our hearts, prayers, and thoughts are with you and with all the Lebanese people.
Thank you.
Dr. Mohammed, I leave you with Dr. Rahal for the Q&A session.
Thank you, Dr. Atmar.
السلام عليكم دكتور محمد. عفوا دكتور محمد. أنا أحب أقاطعكم قليلا. أحب أشكر شوية طبعا ظلمة لأن الكهرباء انطفت. أحب أشكر الدكتور محمد الرحال على آثاره على نفسه والإصرار على تشريفه لنا وإكمال المحاضرة معنا رغم الظرف القاسي اللي مر به شعبنا في لبنان والجهد اللي عليه والأحداث المريرة والخسائر اللي صارت في مختبراتهم وفي جامعاتهم واللجان المكلف بها. فأكرر شكري له باسمي وباسم مجلس كليتنا وجميع أفراد كليتنا على إصراره وتحمله هذا العناء والمشاركة في مؤتمرنا. كل الشكر والتقدير لك دكتور محمد رحال.
نحن هذا يعني من دواعي يعني فخرنا أن نشارك معكم، وإن شاء الله يكون يعني نحن قدرنا نوصل للرسالة أو نفيد ببعض المعلومات اللي عرضناها. شكرا لكم أتحتونا الفرصة ونشارك معكم بهذا المؤتمر.
ممتنين، شكرا لك على اشتراكك في مؤتمرنا. ونترك الآن لدكتور محمد المشهداني لعرض الأسئلة والأجوبة. شكرا.
تمام. Thank you, Dr. Munder. And thank you again, Dr. Mohammed. And we are very sorry about what happened in Beirut. God bless you and all Lebanese people. I would like to mention about the assessment tool. In our college, we did the same assessment tool, including report, assignment, online quizzes. I need your opinion about the final exam. It is open book like in Iraq, or there is another way?
Yes, it is. Yes, the final assessment, it is open book, but we did some kind of assessment that students don't have the chance or don't have the time to open the book. The exam was challenging, and it was time restricted. They don't have time. Of course, the students, they find means, different tools. But what we did, we know that in the spring semester, we had to finish the semester with the least damage. But for the summer semester, we prepared well. Now we are doing the assessment, and some students, they find very difficulties to pass the course because they need to be well prepared. If they are not well prepared, if they are depending on communicating with their colleagues, they don't have that time because, and some courses are more difficult to do, like calculation-based courses. We change the numbers of different versions. Students don't know which version they have. So this was solved. But other courses that are only selection of terms or definitions, it's still, we have difficulty with controlling these assessments. Any other question?
I think Dr. Mohammed cannot hear you. Just 1 second.
Did you hear me or did I?
I hear you very, very well.
Now, Dr. Mohammed is with you.
Can you hear me, Dr. Mohammed?
Yeah, I hear you, but you didn't hear my answer?
Okay. I hear my answer, your answer, sorry. Another question, does all Lebanese School of Pharmacy follow PharmD program? It is essential to complete all 6 years, or it's optional?
No.
For students?
No, it is optional. The requirement to practice is the bachelor degree, 5 years. But the PharmD is an add-on degree 1 year after graduation, and it's optional for students. But we have high enrollment in that program, but not all students are enrolled or apply to that program. They know that they have advantage over their colleagues when they do the PharmD, especially if they are thinking, and we know most of them, they think of traveling and practicing in the United States or Canada. So the PharmD is a plus for them.
Right. Another question from Bushra Maruf, Dr. Bushra. They say, during your experience with PharmD, how would you rate the successfulness of this program, and what is your recommendation for those colleges which they do not have PharmD program yet?
I have different view for the PharmD. For I believe that our bachelor degree that has sufficient number of experiential education, 1,440 hours, similar to the PharmD in the United States. We consider I believe that our PharmD program is equivalent to the PGY1 in the United States because we have intensive clinical rotations in the PharmD. In the bachelor, we do 4 to 5 clinical rotations, and we do community rotations, which are enough to equip our graduates with sufficient clinical skills. Our PharmD is much advanced, and our PharmD graduates are not only in our school, in Lebanon, because in the system, in the Lebanese system, for the pharmacist, for the graduate to register in the ministry, they should have done 12 months of practice. So most schools, if not all schools, they integrated the 12 months in the curriculum, in the 5-year curriculum. So the PharmD is an extra degree, but because in the Lebanese Ministry of Higher Education, they don't have the PharmD, they have the bachelor, so we have to do the bachelor, and the PharmD is, now it is recognized as a post-grad degree. It's not a professional degree like United States. It is the professional degree. Now our professional degree is the bachelor degree, and the PharmD is considered as a postgraduate degree in the Lebanese Ministry of Higher Education. In our experience, not only in our university, but in the all Lebanese university, it well-trained students in clinical settings.
Okay, I agree with you. In Baghdad, there is a plan to start PharmD at 2023. I don't know if you know this information or not. Do you prefer to start partially with a sample of students and then grow up, or start with the full farm degree for all students? Which is better?
From other some schools experience, like in Jordan and in Saudi Arabia, they have parallel programs, one for bachelor and one for D. So the Farm D is a different track from, although some courses are common for at the early levels, but they have a track for the Farm D from the beginning and a track for the traditional degree, bachelor degree. I think this is because in their degree, I don't know if in Iraq is the same, they don't have enough experiential education hours or in their curriculum. In our curriculum, we have it integrated in the curriculum. And now in some universities in the United States, they have what's called accelerated Farm D program in 5 years, or in 3 years after the pre-professional years. So it's similar to our 5-year program, because our students, they also study during the summer semesters. So the academic year in the 3rd year and the 4th year is 12 months, not 9 months.
Right. Okay. At the end, I will thank you again for your informative presentation. I hope to connect together again with a better situation than this situation.
Inshallah.
And thank you again, inshallah.
Thank you.
And I will go back to Dr. Asmar. Thank you.
Thank you.
Thank you, Dr. Rahal. Thank you for answering the questions and for joining us today.
Thank you.
So at the end of our second day of our first international virtual conference, I'd like to say a big thank you to all our distinguished speakers for their informative lectures, for their nice presentations, and for giving us ideas that some of them we already implemented, and some of them we're thinking of doing them, and to give us the courage to continue with them. Thank you, Dr. Rahal, Dr. Alsheef, Dr. Zorek, for your talks and for joining us. And I hope to see everyone tomorrow for our final day at the conference, where our master's students are going to present their work, the work they've done through their studies at the College of Pharmacy. Thank you very much, and have a nice evening.
You too. Thank you.
Okay, thank you.